We're live.
Good afternoon, and thank you to all of those in the public who are tuning in for our final board meeting of the calendar year. And hello to all my fellow commissioners. We have a full agenda today. I'll just take a minute to run through the plan. The first half of the meeting is going to focus on the role of private equity in healthcare. First with a presentation from Dr. Song, who's joining us from Harvard Medical School, and he will provide a national perspective on trends, impact, and policy. And then a second presentation from our HPC research team focused on the trends in private equity in Massachusetts healthcare. So combining both an understanding of a national perspective and our state level perspective. We'll then review notices of material change that have been filed since our last board meeting, have a discussion and recap about last month's healthcare cost trends hearing, both what we learned at the hearing and feedback that we've gotten since about the hearing, and then look back at the work of the Health Policy Commission over the course of 2023. And then David Seltz, our executive director, will close out the meeting with his report, which will include a vote to renew our lease at the 50 Milk Street location for the HPC. So our first order of business today is to consider the minutes from our last board meeting on September 13th. And I'd like to turn it over to Hannah Klumek to take us through the roll call vote.
Thank you so much. So first I'll ask for any amendments to the minutes from September 13th. And seeing none, could I get a motion on the vote?
So moved.
Great, thank you. And a second?
Second.
Thank you. Okay, I will start with you, Chair DeVoe.
Approved.
Thank you. Vice Chair Cohen.
Approved.
Thank you. Commissioner Blakeney.
Approved.
Thank you. Commissioner Cutler.
Approved.
Thank you. Commissioner Foley.
Approved.
Thank you. Commissioner Haupt.
Approved.
Thank you. Commissioner Master Giovanni.
Approved.
Thank you. Commissioner McGregor.
Approved.
Thank you. Commissioner Kwasnick.
Approved.
Thank you. And Secretary Walsh.
Approved.
Thank you so much. The minutes are approved and we can move forward.
Thank you. So we'll move to the first agenda item. I'll turn it over to David Seltz to introduce our topic on private equity in healthcare.
Thank you, Chair DeVoe. Good afternoon, commissioners and members of the public watching here today. Good afternoon, Secretary Walsh. Thank you for being with us today as well. I hope everyone is doing well and enjoying this holiday season. We are looking forward to closing out this year at the HPC with another jam-packed agenda and really an opportunity to do a little bit of looking forward on some topics that I think will be a part of the HPC's agenda in the coming year, and a little bit of reflection on the work of this past year. So the first part of the meeting, as Chair DeVoe said, is really going to focus on a topic that has become, I think, of growing and great interest to policymakers, health policy experts, market participants, and that's namely the increasing role of private equity investment in care. This topic was mentioned a few times at the cost trends hearings, and in my opportunities to talk to health policy people in other states. This is something that many other states are thinking about. What is the role of states in being able to track and understand this growing trend? Of course, the growing role of private equity investment is of course not limited to healthcare. We've seen increasing trends in other sectors such as real estate and technology and education. But the role of private equity in healthcare, both in the United States and in Massachusetts, I think raises some unique questions and potential concerns. As we'll hear today, there is compelling emerging evidence of an association between private equity and healthcare, and some negative impacts on pricing, utilization, and quality of patient care. These dynamics can clearly have an impact on our stability to the healthcare cost growth benchmark, as well as impact overall market functioning and provider stability. And beyond those factors, private equity investment and arrangements may also impact the status of healthcare workers that are working in private equity backed providers. And yet there is a real striking lack of transparency about where, when, and in what healthcare sectors are private equity firms investing. Next slide, please. That is why we included for the first time in our cost trends report a recommendation, a sub-recommendation on our market oversight authority to increase to make clear that our market oversight authority should require the public notice of significant private equity investments in healthcare in Massachusetts, similar to other significant market transactions that are noticed and reviewed by the HPC. You can see that excerpt of the recommendation on the slide here. As we continue to work with the legislature and the Healy-Driscoll administration on the necessary statutory changes to make this recommendation possible, we wanted to take a step back today, though, and provide you commissioners and the public with really an introductory presentation on what is private equity, what is the role of private equity in healthcare specifically, what are some recent national trends, and to give you a review of some of that emerging academic literature that I talked about before on the potential impacts. And to provide that introductory overview, we could think of no one more qualified than Dr. Zuri Sung, who is joining us here today. Following his presentation and opportunity for discussion with the board, I will then turn it over to our HPC research team to present new novel information on private equity transactions in healthcare specific to Massachusetts. And as you'll hear, we had to deploy a number of really unique methods and proprietary data sets to compile this research, given the lack of public transparency in this space. To our knowledge, this is the first research of this type on private equity transactions in Massachusetts healthcare market that has ever been released publicly. And finally, I do anticipate that this is going to be an ongoing topic of research and policy interest for the HPC throughout 2024. So today's meeting is really intended to kind of lay the groundwork for those future deliberations on a potential additional policy levers for strengthening oversight and accountability. But first, it is really my honor to turn over the presentation here to Dr. Song. Dr. Song is an associate professor of healthcare policy and medicine at Harvard Medical School and a general intern at General Hospital. He's a frequent collaborator and thought partner to the HPC. And every time I've had the opportunity to hear him present, I have learned so much. And so I'm really grateful that you were able to take the time today to be able to present to our board and to our public audience here today. I will note, commissioners, I have had a preview of Dr. Song's presentation. There is a lot of slides and a lot of information. And so please, if in the course of his presentation, if you have questions or comments, please feel free to use your raise hand function, and we can pause the conversation and engage in that discussion and comments. And of course, we'll pause at the end for further discussion and questions. With that, I'm really pleased to turn it over to Dr. Song. How are you?
Thank you so much, David. Good, thank you. I hope you're doing well as well. Thank you to Chair DeVoe, all of your commissioner colleagues, to Secretary Walsh and other colleagues here. It's an honor to be with you and to share some of this work with you that many colleagues and I have done as several teams in the last few years. Let me first share my screen. Can you see this?
Yes.
Great, thank you for confirming. I will speed through some of this and slow down at other parts. My goal is to show you the data we have on trends, impact, and a discussion of some of the policy levers available to both states and federal policymakers. So the first part we'll go rather quickly through. we have, as a delivery system across the country, roughly somewhere in the neighborhood of 3/4 of doctors today, either employed by hospitals or health systems or other corporate entities. At the same time, hospital mergers, both within markets and across markets, continue to happen year on and year out. The cumulative effect of these mergers and these acquisitions of physician practices is often seen through reflections of prices. But even before we get to the data on prices, we see that there is a diversion or a widening of the gap between hospitals and health systems and hospitals not in health systems. For example, Commissioner Cutler has led a lot of work in this regard, both here at Harvard University and at the National Bureau of Economic Research. On the right here are examples of so-called cross-market mergers, but in reality are simply large health systems merging with other large health systems, these all within the last few years. I'll show you a few examples, just canonical examples in everyday life of our broader healthcare economy and our economy at large that pertain to healthcare services in terms of consolidation and acquisition. This is not all private equity, but I'm using this to put familiar entities, places perhaps where you and I have shopped in the past, in the context of a more narrower focused discussion on private equity. And I want to use this to put private equity in the appropriate context. So as an example, our nation's largest online retailer, Amazon, acquired One Medical, our nation's largest so-called pharmacy chain, if you will, but much more than a pharmacy company. CVS has acquired Oak Street, a primary care delivery company. And there's been a 10-year deal between Walmart, the nation's largest employer, and the nation's largest insurer to also use direct healthcare delivery. And in these three examples, what I want to show you are versions of what you might call an iron triangle of sorts. And in effect, what it looks like is a self-insured entity, sometimes a large employer here, with a pharmacy function here, as you see in the Amazon example, now direct ownership of healthcare delivery within that entity. In the case of Amazon, it's One Medical and previously Iora Health for the dollar amounts shown here as reported. In the second example, CVS, certainly a pharmacy function, acquiring Aetna, certainly a self-insured or insurance function, now owning direct healthcare delivery in the form of primary care physicians, as well as home health providers. In this third example, our nation's largest employer and our largest insurer, owning now roughly 70,000 physicians across over 2,000 clinics in the direct delivery of healthcare services, both to its insured members, but also to others. And this is the larger scope of the corporatization of both primary care practice, but also healthcare delivery more broadly. This, again, is not all private equity. Private equity is a small, narrow slice of that. It's also occurring in the context of the privatization of insurance. Here's 10 short years of history for you in Medicare Advantage. As many of you know, we've eclipsed the halfway mark between Medicare beneficiaries today being in traditional Medicare versus Medicare Advantage. We're on a national average level, just above 50% in Medicare Advantage today. So in this context, what we hear very often is the growth in healthcare prices. And indeed, healthcare prices compared to the prices of everything else in society continue to diverge from each other here over the last 23 years or so. And put it at a level context relative to Medicare, you see that in a review of roughly 19 studies on prices, the ratio of commercial to Medicare prices is basically 2 in the hospital setting, a little higher, 2.6 in the hospital outpatient department setting, which has been one of the fastest sectors of growth in healthcare spending over the last couple of decades. And in the physician context, it's about 1.4, so closer to 1, but still meaningfully above 1. And when we think about the policy context of addressing this and thinking about where private equity might target, one helpful framework is a simple box that describes healthcare spending. If you take the surface area of a box as healthcare spending, then it has to be that the surface area is the product of the prices of services times the quantities of services. This, as you know, has been talked about in many contexts before. But what I want to lay out is just some of the classic policy levers we have to touch on prices and quantities. Well, regardless of the sector of the economy we're looking at, there are only two things conceptually that toggle prices. One is competition and one is regulation. And as we know, competition between healthcare providers is actually diminishing these days, not increasing, thus leaving regulation over prices perhaps the only available tool left for policymakers. Not saying that it's easy or practical, but just conceptually so. On the quantity side, we have several levers: prevention, keeping a population healthy, changing eligibility, which again is something that insurers can do overnight, but not something normative that everybody agrees with. Coverage being the analog of eligibility instead of who's eligible for health insurance and thus healthcare spending. It's what's eligible under a benefit design. Capacity is how many hospitals or you build, or ORs you build, or scanners you build, or clinicians you train, and of course, managed care, all of the tools at the point of care to constrain or affect utilization. These are the sort of seven classic levers. And in our day and age, we've also considered episode-based payments or bundled payments that carve out a piece of this box and pay it prospectively, often risk-adjusted with a quality bonus. And of course, taking the whole box as a whole and calling that a global budget or a global payment or an ACO contract or a risk contract, paying that prospectively in a risk-adjusted manner with a quality incentive. And often using still the fee-for-service underlying train tracks to pay for these services with an end-of-year reconciliation on the budget. In this context, private equity pertains to this in several ways. First, prices are important, as I'll show you. Second, many private equity acquisitions today are at least done in a public out-facing way, despite the lack of transparency, in a way that's connected to value-based payment. There are many private equity acquisitions that are made with at least a spoken goal of helping providers adapt or engage with value-based payment, which is one of these prospective forms of payment. And that is actually a really interesting margin on which hopefully we'll have some discussion, but where there's relatively less evidence to date. So stemming from this quick, simple framework of healthcare spending and policy levers, I want to show you two wrinkles on prices that matter to private equity. One is this out-of-network issue. So in a simple descriptive paper a few years ago, you see here that Medicare prices versus commercial in-network prices versus commercial out-of-network prices follow this traditional monotonic increase. Medicare prices are lowest, commercial in-network prices are next highest, and commercial out-of-network prices are highest after or higher after that. That ends up mattering because private equity firms have often staffed physicians into clinical situations where out-of-network care is relevant. For example, surprise billing scenarios in emergency departments or in anesthesia. But that's also not the largest part of private equity activity. What might be larger is this rural-urban market power divide at the market level. So in another short paper here, you see that Medicare fee-for-service prices here on the right for 3 common hospitalizations pale in comparison to the same hospitalizations within commercial insurance. But the commercial population prices also differ based on the level of competition among providers in a market. So it turns out that rural providers, in this case, rural hospitals, have relatively more market power than urban hospitals for the same DRG, for the same price on the same hospitalization. These numbers here in the box are simply the percent ratios relative to Medicare. So this matters to private equity because we see a lot of private equity activity, not so much in the urban areas of our country, but more so in the suburban, bordering on rural areas of the country, where hospitals and nursing homes and even practices are more likely to be so-called the only game in town or lacking provider competition. All right, so private equity, it's merely one particular type of corporate ownership. Again, it is not the entire scope of corporate ownership that I tried to set out earlier. It's a narrower slice, but it's an important slice both because of its growth recently and because of the differences in the classic business model. So I'll try to walk into some nuance here and slow down a little bit, but the introduction to this section comes from a story that has been often told in the health policy world and in the policy literature around Hahnemann Hospital. Without having to go into this in great detail, this brought a lot of attention among researchers and policymakers to this business model of private equity. It remains the exception rather than the rule, but it's an important exception to illustrate some aspects of the classic business model. So if we take a step back and look at the landscape of private equity activity in healthcare, these bars and this line graph shows you basically the deal volume, the number of deals, and the total amount of the dollars involved. The ups and downs are less important in the sense that private equity activity has classically followed stock market and interest rates. When interest rates are low and stock markets are doing well, private equity activity tends to pick up. When interest rates are high, private equity activities tends to slow down. There tends to be so-called more of the quote unquote dry powder or investment dollars not yet used in those years, but it picks back up as the cyclical nature of market activity proceeds. But the important thing is the cumulative buildup of this. If you just add up the bars year after year, we as a society or as a nation continue to see cumulatively more and more private equity activity, even if there's a slowdown in a particular year or two. When we look at the last 5 years here relative to the 5 years before that, we see a large increase in acquisitions of healthcare providers. That's this gray box here on the left. Payers and medical technology firms or companies, that's important too, but provider acquisitions have really picked up pace. On the right side here, we see that there's also been an increase in biopharma, not just in the US or North America, but also globally. Many of these biopharma deals actually border on looking more like venture capital acquisitions as opposed to private equity acquisitions. And I'll show you a table that distinguishes the two forthcoming. So here's an attempt using what we know anecdotally and with the academic literature around private equity to depict the classic private equity acquisition model. This is, I want to emphasize, the classic model. It is not the case that what I'll show you here on this slide applies all the time to practice acquisitions or hospital acquisitions or nursing home acquisitions. It is a classic business model that was born out of the 1980s that for the first 20 or 25 years largely did not have much to do with healthcare delivery. But around the turn of the century in 2000 or 2005 or so, acquisitions of hospitals picked up pace. Then around 2010 or so, acquisitions of physician practices picked up pace. All along that period, acquisitions of nursing homes accelerated quite rapidly. So this is a classic business model that pertains to the 80s, the 90s, the 2000s, and indeed still today, but I want to recognize the variation around this model today. All right, so in the classic business model, there is a private equity firm that raises a fund here on the left in this gray box. The fund is a pot of dollars that investors support or put money into. From the fund, there's an acquisition part of that fund to keep the framework of the prior slide, simply a blue box, denoting a number of dollars here used to acquire a healthcare entity. In the classic business model, a relative minority or smaller share of this box is actual equity that comes from the investors and the parent private equity firm. The investors are sometimes called limited partners. They contribute in the classic model the vast majority of this actual equity in the acquisition price. So in a 30-70 split in the acquisition price, in the classic business model, the limited partners will contribute 98% of that, let's say, leaving 2% of the actual equity coming from the parent private equity firm. The other 70% of the acquisition price is borrowed. This is one of the distinguishing features of private equity, so-called leveraged buyout. The leverage is the loan, is the debt-financed nature of the acquisition. So 70% of this blue box is borrowed, say, from a bank. That acquisition price, this blue box, is used to acquire a provider, whether a hospital or physician practice. And if you think about what's 2% of 30%, well, that turns out to be less than 1%, technically 0.6%. So 0.6% in this classic example of the acquisition price comes from the actual backroom equity of the parent private equity firm. The rest of it is society's dollars elsewhere. And when the provider is acquired, every acquisition comes with an exit strategy. Another distinguishing feature of private equity is the short time holding of the acquired entity. Often entities are held for 3 to 7 years, sometimes 2, sometimes 5, in that sort of order of magnitude before they are sold again. In physician practice land, just to give you a concrete example, about 2/3 of private equity acquisitions are sold to a secondary private equity firm. So that's another PE firm after the first firm has held it. Another 20% are sold to corporate entities, thus linking us back to the initial slides of literally Optum, the CVS, Amazon. These are examples of corporate entities that purchase physician practices from private equity firms. And another 5 or 10% go public in an IPO. The other important thing about this general framework, besides the amount of debt, the short acquisition window, the exit strategy, and the loan, is that there are 3 streams of dollars that flow in this diagram. And this is how private equity firms make this business model relatively profitable with relatively low financial risk. So the first is that there are often management fees from the investors to the private equity fund. That's on the order of magnitude of 2% of the value of the fund annually. There are sometimes also management fees from the acquired entity, not always, back to the private equity fund or the parent firm. These 2 streams of management fees, if you just add them up and you hold an acquired entity for long enough, given, generally speaking, a few years, those management fees typically exceed the 0.6% of the acquisition price that was actually the equity of the parent private equity firm. So just by holding the entity for long enough, technically speaking, the financial risk of the parent private equity firm is exceeded by the management fees alone. But most of the revenue, most of the profits at the end of the day come from the sale. So after selling the acquired entity, Typically, the first X percentage, called a hurdle, the classic model would be roughly 8, let's say. The first 8% go all to the private equities limited partners, all to the investors. And after that, from percentage 9 through 100, that's split between the investors and the parent firm. So in a classic model, it'd be 80% going to the investors, 20% going back to the private equity firm. That's where most of the dollars are. So if you add up these 3 streams of returns to the parent private equity firm, and you think about how much equity was put in the first place, that basically gives you a relatively low financial risk scenario with plenty of moral hazard, arguably, and the limited partners and the bank mostly on the hook for their returns, mostly waiting for the returns. The banks get a fixed return. The limited partners are waiting for the sale. In this diagram, what's not shown, but importantly in terms of nuance, are many of the financial engineering strategies used by private equity firms to generate returns. Financial engineering strategies include things like dividend recapitalizations, where parts of the provider entity perhaps are turned from physical assets into additional debt. So this ratio of debt to equity further tilts toward this debt side, but that allows the parent private equity firm to sell off some of the assets in the near term in order to give returns to the investors quickly, immediately after acquisition. Other strategies include separating out a provider entity or an acquired entity into an operations company and a real estate company. Basically, the land, the buildings, the physical assets versus the operations. The physical assets then can be sold often to other companies, sometimes to real estate trusts, as noted earlier, while the clinical operations are maintained. That's another way to generate returns for the investors in the short term. There's also the use of bankruptcy, which I won't get into just for the sake of time, but there's a variety of financial engineering strategies. The last point I'll note here is who are the limited partners in our society fueling this business model? And I think in a very, very introspective way, at least from a policymaker's perspective, at the end of the day, it's all sort of us in society, so to speak, because some of the largest investors in private equity today are US pension funds, university endowments, other private firms, including hospitals, sovereign funds of other nations, and the wealth of wealthy people. At the end of the day, investment dollars come from many entities in society that we are very familiar with, and private equity firms provide a mechanism for those investment dollars to generate higher returns, say usually on a 10, 15, 20% returns level, as opposed to 5 or 10 in a traditional investment that you might consider. All right, now I'll run through some of the evidence and take you through a slightly deeper dive of the evidence in hospitals. Before going there, I want to make this contrast noted earlier versus venture capital. Venture capital tends to go after early stage ideas with smaller amounts of investment capital, looking for larger returns in terms of multiples. So in this canonical example, you might say a smaller amount invested, looking for home runs, a 50 to 100x return in early stage ideas that may not work out. Whereas private equity tends to go after majority stake ownership or sometimes full ownership, often full ownership, with large amounts of capital invested for lower multiple returns, but more certainty of the return. So usually mature, successful businesses in the classic model since the 1980s is typically where you see private equity activity. There is some distressed investing of companies to turn it around using management expertise, but in the grand scheme of private equity activity, distressed investing is a rather small slice of total acquisition activity. Most of it is of mature, successful businesses. So in healthcare, here on the left is a map of US hospitals as of a few years ago that have been acquired. Hundreds of hospitals have been acquired today. This is just one snapshot in time. Many of them are no longer owned by private equity because they have been sold a second or third time. Here on the right is a market level analysis of physician acquisitions and the penetration across the US. Hotbeds, if you will, include the Southwest, Arizona in particular, Florida, the Southeast, parts of the Midwest, parts of the East Coast. And what I want to do is give you a general overview of what we know about hospitals and physician practices, and then give you a sense of what colleagues around the country have found in other settings as well as these settings. I want to emphasize that a lot of this academic work has been done by many outstanding colleagues, both here at Harvard and at other universities, whom I hope to credit appropriately throughout our time today. And I'll start with this paper done by led by Dr. Joe Brutch, who was a former PhD student of mine here at Harvard. He's now an assistant professor at the University of Chicago. This was part of his dissertation work and co-authored with Suhas Gandhi, one of our Harvard medical students, now a Brigham and Women's resident. This looks at financial performance after private equity acquisition among about 200 private equity hospitals compared to roughly 530 matched controls. You basically see here on the right a representative finding. This is a charge to cost ratio, essentially the asking price divided by the reported costs. Time zero here is the point of acquisition. Before acquisition, this economic or financial outcome is rather parallel between the two groups. After acquisition, it starts to diverge. That is basically the story that we find in this first study of hospitals. It comes out to be, in a difference in differences way, a roughly 27% increase in net income, a 7 to 16% increase in charges. We see an increase in the case mix. That's either coding intensity or truth. We can talk about that more. And a decrease in the Medicare share of patients who are admitted. Incidentally, the Medicaid share in this study did not decline, though we're finding other instances of Medicaid shares also going down. And the inference here is that the commercial share of patients admitted is going up to replace the Medicare and Medicaid share. To give you a sense more concretely of magnitude, in addition to those percentages, the net income change is basically $2.3 million per hospital on average. And that is not a huge number from a hospital perspective, but still a meaningful change. And in this study, we also looked at some quality measures. And here's where I'd like to take the off-ramp or on-ramp, if you will, into these newer studies we're doing now on hospital clinical quality. This was a first glance at hospital quality, and in my view, a rather insufficient glance by all of us, because all we had at the time were process measures at the hospital level. A process measure set of 8 measures that we were able to combine into 3 buckets: heart failure, heart attack, and pneumonia. But let me just give you a sense of what these quality measures are. The first heart failure measure is that when patients with heart failure are discharged from the hospital, they receive discharge instructions. That itself was the quality measure. And although discharge instructions can be very important, in terms of clinical quality of care provided in the hospital, we did not find that to be overwhelmingly meaningful. And many other measures were of clinical decisions that almost have to be made. For example, to define heart failure, you've got to get an echo, measure the left ejection fraction, left ventricular ejection fraction. You have to give typically medicines like an ACE inhibitor. So these are things that should be done, and we didn't see that as in terms of patient outcomes, or at least intermediate outcomes, to be all that meaningful. So although this paper found mixed results on quality, and it was largely driven by the HCA, Hospital Corporation of America, acquisition in 2006, we wanted to take a deeper look into essentially actual hospital clinical quality of care. And what we're doing here in this work that's forthcoming in about a week or so is that we're looking at these CMS-defined hospital-acquired complications or conditions. They're basically adverse events. By definition, patients cannot have them before coming into the hospital. They can only pick them up while in the hospital. And this is the list of some of the classic complications you hear about, such as central line-associated bloodstream infections or catheter urinary tract infections or surgical site infections or falls. These are the kinds of things we're able to look at with our now Medicare data. So using 100% Medicare Part A and Part B institutional claims, we're looking at roughly 2009 through 2019. And so the 2006 Hospital Corporation of America acquisition is out of this sample. You might say that that acquisition was not the modal or average acquisition anyways. So to the extent that's less representative of what we see today, we're looking at arguably the remaining pool of acquisitions since about 2009. So these are the hospitalization characteristics before acquisition in terms of age, sex, risk, eligibility, race and ethnicity, eligibility for Medicare and Medicaid, that is. And what we're basically doing here is similar to the previous study, matching every private equity hospital to roughly 5 to 8 control hospitals. And we're looking at the difference in differences, or the change over time relative to the control group, of now clinical quality of care in the hospital. And we're adjusting for these characteristics that are not completely balanced with the matching. So here on the left is the unadjusted raw result of the composite hospital-acquired complications. This composite adds up all of those hospital-acquired complications, pulls them into one. And what it basically shows you is that the private equity hospitals here on the left, in the red, their level of hospital-acquired complications was below the level of the control hospitals here in the blue. But immediately after acquisition, the red line jumps above the blue line in terms of the level of hospital-acquired complications in aggregate and composite. So on the left here, there are no statistical adjustments. This is just the raw data. Once we apply the statistical adjustment, we're able to show you here a year-by-year comparison of the so-called event study. So every year, what is the difference between the private equity hospitals and the control hospitals? The takeaway here is basically the same story. In the 3 years prior to acquisition, private equity hospitals demonstrated similar levels, basically no changes in their hospital-acquired complications compared to the control group. But after private equity acquisition, these 3 years afterwards, hospital-acquired complications exceed the control group. This work is being led by an outstanding postdoctoral fellow here at Harvard. Her name is Sneha Kannan, and our collaborator and colleague here is Joseph Bruch, the same Joe that led the prior study. So this is work led by Sneha, both in the general hospital setting here, and as I'll show you in the emergency department setting upcoming. So if you're interested, and I'm happy to just pause here for only a moment, we're basically adjusting for a bunch of things that you might imagine are potential confounders. These are basically observable attributes of either the patient or the hospitalization. So we're adjusting for things like age, sex, race, and ethnicity, a patient's Elixhauser comorbidity score, and their dual eligibility status. We're also adjusting for the major diagnostic category of the hospitalization. We're also adjusting for the hospital itself, which is essentially an adjustment from the catchment area. If the catchment area of hospitals are fixed over time, we're taking that into account. So every unit of the observation here is a hospitalization at a hospital relative to a matched control group in a given year. So in terms of magnitude, what do those graphs show you? Basically, a 25% increase in composite hospital-acquired complications, driven by a 27% increase in falls and a 38% increase in central line-associated bloodstream infections. Those latter infections happened despite 16% fewer central lines being placed in the first place. So despite fewer central lines, we're seeing a higher volume of central line infections. Down here at the bottom, there was also a result that surgical site infections doubled at private equity hospitals while they declined at control hospitals, a result that actually illustrates the two groups are going in the opposite direction. This was despite the fact that 8% fewer surgeries were being done in the private equity hospitals. Now, this result was not as statistically significant, which I'll show you concretely on the next slide. And that's because, in part, hospitalizations involving surgery are much smaller in the sample. They're much less frequent. So among a smaller sample, we have more statistical noise. And so the p-value is not as significant. But it was really striking to us that surgical site infections are moving in the opposite direction between the private equity and control hospitals. So here are the numbers of what I just laid out. Here in the blue up top is the aggregate hospital-acquired complications. This is that 25% increase shown on the prior slide. And what this table shows you is both the pre-level, the pre-acquisition level among private equity hospitals, and the post-acquisition level among private equity hospitals, adjacent to the pre and post levels in the control hospitals here in the next two columns. And so the yellow highlighted rows are those statistically significant findings, the falls, the bloodstream infections from a central line, and the surgical site infections that were less statistically significant. And we're penalizing ourselves here with a very conservative or very aggressive, draconian, if you will, statistical adjustment with the Bonferroni adjustment, which is a conservative way of presenting to you what we feel is statistically significant. And so the composite is driven by all of these things, but the highlighted yellow outcomes, they stand out. And so just as a concrete sense of magnitude, surgical site infections basically doubled from 10.8 to 21.6 in private equity hospitals, whereas it went down from 17.5 to 12.6 among control hospitals. Moving on, I wanted to show you that the volume of these hospitalizations are actually changing in aggregate too. So it turns out that central venous catheters, basically central lines being placed often in the ICU, are placed less often here in private equity hospitals relative to control. So there is this 16% reduction shown here in the level of central lines. Despite fewer central lines, however, we see a higher volume of central line infections. Again, this is adjusted for patient characteristics and the hospital characteristics. In terms of surgeries, we're also seeing fewer surgeries here, a reduction from 161 to 123 relative to the control group that basically stayed the same, and at the same time, moving in the opposite direction in terms of surgical site infections. So what's one of the takeaways here? Well, going back for one moment, falls are typically attributed to the hospital floors, the general wards, perhaps even the ICUs. Central lines are generally attributable to the ICUs, and surgical site infections are generally a matter of operating rooms as well as post-operative care. So at all three levels, if you will, of the hospital, from the ICU to the floor to the operating rooms, we're seeing something here that is concerning. All right, taking a step back before hospitalization, we're also able to look at, with 100% emergency department data, who is coming into the emergency department within traditional Medicare and what's happening to these beneficiaries in the ED. So cutting to the chase here in the similar design with basically the same sample, we're finding that younger Medicare beneficiaries and healthier beneficiaries and beneficiaries who are less likely to be dual eligible are now being treated in emergency departments of private equity hospitals. Despite being younger, healthier, and less dually eligible, we're finding a 12% increase in emergency department mortality. That's a discharge status of death from the emergency department itself. That was driven by a 52% increase in ED mortality for heart attack patients. We also see more transfers out to other acute care hospitals, shown here, as well as an increase in admissions. And I've already shown you what happens to the admissions after patients are admitted. So private equity hospitals seem to be keeping patients who are relatively healthier, younger, and less dual, transferring out the remaining patients most of the time at a higher frequency, and at the same time exhibiting this increase in death. So poking into this ED result on mortality a bit further, we're showing you here, again, with work led by Sneha and co-authored by Joe, this increase in aggregate deaths here at the top level. That's the 12% increase here. It's 6.7. It's an increase of 6.7 per 10,000 ED visits in the Medicare population, traditional Medicare in the ED. Myocardial infarction, so heart attack deaths, are thankfully still low in terms of level. It's a 1.7 that goes up to a 2.4, but the control group's heart attack death levels are actually coming down as well. They're declining from 1.6 to 1.3. That is how we get to the 52% relative increase in heart attack mortality. So even though 52% sounds like a large number, I wanted to put it into context by giving you the actual levels here. It's a 1.7 to 2.4 increase with a decline among the control group. As you can see, heart attack deaths still are less, far less in level than some of these other types of deaths and small part of the aggregate. But if you think about heart attacks as something we have a lot of experience with and something that's often studied in the health economics literature, what might be leading to this? Well, it turns out that when we studied clinical tests appropriate for heart attacks, two of the classic ones would be a troponin test and an EKG, shown here in the pictures. You would expect that these are reflexive automatic services that emergency departments provide for patients with not just heart attack, but even before the heart attack diagnosis. So acute chest pain, unstable angina, even shortness of breath. Many of these symptoms lead to these tests in an often reflexive manner. And yet we're finding that troponin tests and EKGs among patients with heart attack are actually going down in private equity hospitals relative to control. This was surprising because it was hard to imagine even a private equity hospital doing fewer of these reflexive necessary tests for chest pain or heart attack. This may be attributable to a staffing story, and I'll get into that a little bit more, where staffing levels at private equity hospitals, similar to what we've seen in physician practices and similar to what others have found in nursing homes, often go down after acquisition, perhaps down to the level where patients with heart attack or chest pain are not yet able to get all of the troponins and EKGs they were going to get before they clinically declined. That might be the explanation for the reduction in volume here, because otherwise, clinically speaking, this is quite surprising. What about during COVID, where we know that lots of disruption happened in hospitals? So now I'm taking you outside of the 2009 through 2019 period and putting us right around 2020, if you will, and beyond. These are hospitals from my pictures from my colleagues at Mass General Hospital when we had our initial COVID wave. Many people worked extremely hard to make patient care viable during this time, and these are just some of the visual memories I have of my friends and colleagues. During this period, the US had many private equity hospitals. there were many hundreds of them, several hundred, as opposed to the smaller sample we have in the prior studies, because in the prior studies, we have to follow them from 3 years pre-acquisition to 3 years post. Here, we're just showing you what happened before and after the pandemic. Right after the pandemic, there were COVID hospitalizations, of course. And it turns out that relative to control hospitals in the same areas and adjusted for the same factors that I showed you earlier, private equity hospitals had a 2.3 higher, basically, mortality rate of patients who presented for COVID. That's the orange line here exceeding the gray line. That's just the post-COVID period. There was, of course, no COVID pre-COVID. So in a sense, you cannot difference out the pre-COVID period. So this is just a cross-sectional comparison of the post-COVID period. But even during COVID, 85 to 90% of Medicare hospitalizations were for non-COVID reasons. And that's the line here at the bottom. We do have a pre-COVID for non-COVID reasons. And for non-COVID hospitalizations, the mortality rate differentially increased relative to control and relative to pre-pandemic on the order of 11%. So an 11% increase in non-COVID hospitalization mortality among the 100% Medicare inpatient sample relative to control hospitals at the time of the pandemic. So this is a larger sample of both treatment and control hospitals. That's shown to you by the orange line being above the gray for most of these months, right after the pandemic started, where we have all of this hospital disruption. All right, I'll quickly take you through physician practices. Much of this is analogous, but it's a different market, if you will, in terms of healthcare delivery for PE acquisitions. These are numbers attributable to that graph I showed you earlier of penetration into physician markets by breaking it down into the 6 specialties that comprise that earlier graph. These are 6 of the earlier specialties to so-called go into private equity. Many private equity acquisitions are of physician specialties that feature high-priced, quick, outpatient, facility-based procedures, where in the fee schedule, there's a facility fee. In the fee schedule, the RVUs are high, particularly on the practice expense component, and in specialties that are, in many suburban or community settings, still independent and giving private equity firms a chance to consolidate and build market power. So this is the penetration at on a national scale at the specialty level. When we break that down, these 6 specialties, each into their own maps, this is what it looks like. The maps are not all identical, and this is at the state level as opposed to the market level. But basically, you see some similarities in the Midwest, the East Coast, Southwest, but also some differences in terms of just penetration rates of private equity acquisitions. Using commercial claims now, where prices actually differ, we're able to study, in this sense, in this scenario, roughly 570 physician practices acquired by private equity relative to almost 3,000 matched controls in a similarly matched way. This work was led by an outstanding graduate student, Yashaswini Singh at Hopkins, who is now an assistant professor at Brown University in their new center that one of our colleagues, Andy Ryan, runs. And it was also led by my colleague, Jane Zhu from the Oregon Health and Sciences University. And Jane and I are continuing to do a lot of work with the rest of our colleagues here in physician practices as well. In this work, Yashaswini's work, this paper showed that there was a 20% increase in charges, an 11% increase in prices. And the interesting thing here is that before acquisition, again, the levels were basically not changing in terms of the slope. In fact, private equity practices had slightly lower charges or prices. But right after acquisition, in these 4 quarters, you see a marching up of prices and charges. We think that this reflects the seasonality of negotiation. So right after acquisition, you may not have renegotiated your prices yet. But in the first quarter, some do. In the second quarter, some more do. In the third quarter, some more do. By the fourth quarter, you've mostly renegotiated your fee-for-service contracts, or at least your prices with your payers. And so we see then this leveling out at this average level post-acquisition. That's P, that's the vertical side of the box. What about Q, the quantities, the horizontal side of the box? We're also detecting here a 16% increase in aggregate volume. That was driven by a 26% increase in unique patients seen, a 38% increase in new patient visits, and a 9% increase in long visits. And one of the conundrums here, which I'll show you with this paper, and then we'll go right back for a quick second, is that private equity firms, the practices that they acquire here also exhibit in these three of these first 6 specialties that we're able to take a deeper dive into. They also exhibit a replacement of higher cost physician labor with lower cost non-physician clinician labor. This is not a normative statement about our non-physician colleagues. We love our non-physician colleagues, especially in a primary care clinic where I am, that would not function if we did not have our amazing non-physician clinician colleagues, like our nurse practitioners, our physician assistants, our front desk staff, and so forth. But in terms of the cost of operating a practice, as is the classic business model case in private equity land, even outside of healthcare, within healthcare, we see a stripping out, if you will, on the margin of higher cost labor and a replacement of that by lower cost labor. So these bars in this health affairs paper, here led by Joe, the same Joe as before, and Jane, the same Jane as before, show you a replacement of physicians with non-physician labor. So knowing that, and coming back to this for a second, it is striking to us that with fewer physicians and generally a reduced staff, as we see in hospitals as well, we're seeing more visits, more patients, and on average, every visit is longer. It's not clear with a 24-hour day how that's possible. But this may be a coding effect where level 3 visits are coded as level 4 and 5, level 4 visits are coded as level 5. We've seen that in other settings of Medicare fee cuts, not included in this slide deck. But that's just a striking finding on volume and on staffing. All right, now in some of our emerging work on physician practices, this is not yet out. We're seeing here on the left a relative increase in professional fees, but less so in facility fees here on the right. And what this is meant to show you, this is work led by Yashaswini and Jane again, is that not every private equity acquisition follows the same financial story either. You may see instances where facility fees drive the spending increase through the price avenue, as opposed to quantities. But at least in this case of GI practices, where endoscopies and colonoscopies and these procedural services have both facility and professional components to their fees, it is a story of a relative increase in professional fees, the 78% increase, that drives the spending increase of 28%. Here on the right, the graph does look similar, so I will grant you that if you just look at the red dots, it suggests a similar story. We just do not have the same level of statistical certainty here on facility fees, and we have much more certainty here on for professional fees, just illustrating the variation in the story. I now want to give credit to many of our colleagues at Cornell who have also, in the same time period, done a lot of great work on private equity. Here's one paper on dermatology practices showing a 3 to 5% increase in prices. That's a smaller increase than what we find in fair health data. I believe this is a different data set, but on the same order of magnitude. This is a study done by similar colleagues, both at Cornell and at Berkeley, showing another wrinkle, another element of the private equity marketplace, which is that PE firms may not only acquire hospitals and physician practices directly, but they may often acquire physician staffing companies. So here's an example of physician staffing or management companies in anesthesia that are acquired. In the same pre-post relative to control kind of way, what they're showing you is that basically prices go up after acquisition. And going back to that initial wrinkle about prices I showed you earlier, the proportion or the likelihood that the clinician is out of network also seems to increase. What's interesting is that the out-of-network share and these measures of prices go up when the physician management company is owned by private equity relative to when the physician management company is not owned by private equity. So the physician management company itself has a role to play. You can see that relative to control, the physician management company is already higher in terms of prices, and here similar with the confidence interval. But when you add on private equity ownership on top of that, it seems to exert an additional effect on prices and out-of-network likelihood. How does this benchmark to some of our best evidence in economics? This work from other colleagues, slightly older paper, shows that when physician markets concentrate or consolidate, they obviously lead to higher prices. We know that from 10, 20 years of empirical literature, but the magnitude is interesting. The magnitude depends on the market structure. So on average, when you reduce, let's say, 30 practices in a market down to 29, you may not see all that much of a price increase. But when you reduce 3 practices down to 2, you see a more obvious price increase. Here in cards and ortho, roughly a 10 to 14% magnitude of change in their prices. Benchmark to this, the private equity effect that we're estimating from physician practices is in the same ballpark. When you ask physicians how they feel about private equity, they generally give you a sense that it's roughly comparable, perhaps on par, perhaps a bit different, though roughly comparable to other forms of ownership. In this survey led by my colleague Jane with other colleagues, you see that the much better to much worse, they do garner some responses, but most of the responses are in the middle. Compared to ownership by a for-profit hospital or health system, ownership by private equity, most people say in the middle, about the same, maybe sometimes better, maybe a little bit more, sometimes worse. We don't see a huge deviation in terms of physician opinion. As I'll get into in our final slide coming up, there is ample reason to believe and a sensible set of reasons that physicians prefer the option value of being acquired by private equity, especially physicians toward the end of their careers. But before that, I'm going to show you just a very quick glance through what you might call from the beginning of life to the end of life, so to speak, just a rough sense of what we know descriptively about private equity elsewhere. So at the beginning of life, so to speak, we're seeing a lot of acquisitions of women's health practices, including OB/GYN offices. This is a map, again, led by Joe a few years ago, showing these acquisitions. At the beginning of life, also, we see private equity investments in fertility clinics. So 8 out of 11 fertility chains have private equity investment. Doesn't mean they own every one of them, but they're invested in them. Total IVF prices, 40 to 60K, depending on how many cycles. And acquisition has been shown to be associated with a 28% increase in the volume of IVF cycles, but also an increase in the success rate. And this is an area of medicine where there are fewer guidelines, obviously driven more by patient preference, consumer preference, provider preference. This is not a heart attack and troponin and EKG type of reflexive scenario. And we're finding that utilization goes up, but of course also success rates go up. So the normative implication is a bit more nuanced. From the beginning of life towards what you might call toward the end of life, taking a stop here at nursing homes, we see that private equity acquisition increases several outcomes, clinical and economic, in nursing homes that are also concerning, at least societally or to policymakers. An 11% increase in ED visits, a 9% increase in hospitalizations, a 4% increase in Medicare spending, and in this paper on the right, roughly a 10% increase in mortality. This paper on the right was led by Atul Gupta of UPenn, who did an outstanding MBER working paper looking at nursing homes here. And that's a arguably more causal estimate if you think about the economics methods used here. And our colleagues previously noted from Cornell, a study here on the left with the graph here of nursing home acquisitions, giving you these other results in this yellow box. All right, finally, on this quick tour from the beginning toward the end of life, private equity acquisitions are also seen increasingly in hospice. And our colleagues and many of us are starting to trying to understand this area as well. In this light blue line here, you basically see this descriptive increase in the proportion of beneficiaries using private equity-owned hospices. On the right here is private equity in the light blue compared to, in the orange, compared to the publicly traded forms of hospices, also for profit, but publicly traded here in the light blue. So just in general, hospice facilities in the US over the last couple of decades have continued to be increasingly more privately owned or corporately owned. And the payment system for hospice has not changed. And the final result I'll show you from our colleagues here suggests that there has been a 6% increase in patients with dementia admitted to hospices owned by private equity relative to control. Now, why dementia? So I mentioned the hospice payment system hasn't changed in Medicare for several decades. In previous decades, patients with cancer tended to dominate the sample or the pool of patients in hospice. Hospice payment systems are, the Medicare payment system is complex, but essentially you could think of it as a prospective payment system where the resources you don't use are able to be kept by the provider. And in this case, patients with cancer tend to use more healthcare services towards the end of life, whereas patients with dementia, on average, use less resources towards the end of life. So patients with dementia are seen generally as more profitable to owners of hospices. And so we see a relative increase in the share of patients with dementia in hospices owned by private equity, potentially consistent with that story, at least so far. All right, finally, let me just land here. One of our great residents here at the Brigham and Women's Hospital, Christopher Kai, and I wrote this short article earlier this year on a policy framework for addressing private equity penetration into healthcare delivery markets. And what this shows you in an acronym that does not roll off the tongue easily, FAMPT, is just a list of levers at the federal and state levels that we've talked about in many other settings that also pertain to private equity, which states or federal policymakers might pull or consider pulling to try to address the clinical and economic impacts of private equity. So they include fraud and abuse, such as the anti-kickback or START clause, antitrust. I would say that this is really important because I think among many economists, especially, the general consensus is that the rise of private equity and corporatization may reflect a general lack of stringent antitrust regulation in our healthcare delivery system more broadly. And this is a further symptom of that, as opposed to a completely different story. At the state level, we have corporate practice of medicine laws that might be potentially used. State AGs could have more authority. Although if we have our history right, the state of California tried to give the attorney general veto power over private equity acquisition of healthcare providers, but that was not allowed at the end, partly because physicians, the physician community, we believe, I think the history is the California Medical Society opposed that measure. And there's ample reason to believe that physicians, especially towards the end of clinical practice, would benefit from an influx of capital and a private equity acquisition. Indeed, many physicians towards the end of practice will receive a very generous buyout from private equity firms with an ability to ramp down their clinical activity and forego many of the practice administrative responsibilities that a private equity firm can take on. That is quite attractive to private practice clinicians, and it's understandable. So it's also understandable that physician communities might oppose measures to take private equity off of the potential acquisition opportunities list. At the federal level, the FTC, we've heard talks about this in other settings where folks from the FTC have talked about staffing and bandwidth to oversee or regulate consolidation activity broadly. Some of that is PE. Moral hazard is also a really important element here. And that goes back to the initial diagram of very little of the parent private equity firm's own assets being used in the acquisition price. Most of it is borrowed money. And then most of the rest of it is investor money. And so when private equity firms purchase physician practices, and nursing homes in many cases, they often purchase a platform practice, perhaps a larger or more established practice in the community, and then add on to that through the quote unquote roll-up strategy. But it turns out that from a legal perspective, if one of these practices in the roll-up strategy goes into bankruptcy, perhaps under the weight of the debt that's put on them soon after acquisition, the parent private equity firm is generally not liable or responsible for that bankruptcy. It may come back to affect them through further investments by their investors, but legally speaking, they're separate. So one way to tie back accountability to the parent private equity firm is to reaffiliate them, the so-called affiliation rule of tying them back, so that if one of them goes into bankruptcy, the parent private equity firm has to use some sort of its own equity to support that. In, let's say, grocery stores or toy stores or manufacturing or cars and other markets where private equity has had a lot of activity before healthcare, we see that bankruptcies of acquired entities often place the workers of those large companies into federal responsibility for their pensions as well. The private equity firm generally, for workers who are laid off, are not responsible for the pensions of those workers. They go to the FDIC equivalent of pension protection at the federal level. Taxpayers back that up. Second and third, I'll go through very quickly, is to limit the percent of debt used in an acquisition. I showed you the classic model of 70-30. Often it's 80-20, often it's 60-40. So the percent of debt is important because immediately after acquisition, the acquired hospital or physician practice or nursing home feels this pressure to increase the cash flow, increase revenues, to start paying down interest on the debt. That is a big difference relative to an academic medical center's acquisition or relative to a not debt-financed acquisition. That pressure to increase prices or quantities to pay down interest on the debt changes potentially the clinical delivery of care on the ground. And if you limit that from a policy perspective, perhaps that changes the moral hazard and the financial incentive. There's also the carried interest loophole. The quote loophole basically refers to the fact that private equity investment income is taxed at 20%, as opposed to the more 35 to 40% roughly range of income taxes for so-called regular income or corporate income. So This is basically a tax benefit for private equity revenues or profits that does not exist in other parts of our economy. Protecting patients and prices, I won't go through that in detail. You can see here things that are very familiar to all of us in this room. And then transparency. There is an act at the federal level that the threshold changes every year, but recently it's been at $111.4 million. That's the threshold for mandatory reporting of a private equity acquisition to the SEC or to federal regulators. So that threshold basically exceeds the acquisition price of most physician practice acquisitions. And this is why many physician practices are acquired right across the street from you or right under your nose without anyone noticing it. There's no interview, there's no newspaper article, there's no study. These acquisitions tend to be quiet in and quiet exit. And so changing this threshold, either at the state or federal level, and there's been some discussion about this here in Massachusetts, may at least shine some more light onto private equity activity. And here's a map of our corporate practice of medicine laws in a New England Journal paper just recently by our colleagues. All right, I think I'll stop there. I have 2 more slides here, which maybe we'll go into in the Q&A, but we're after the hour by a few minutes. So let me just pause here and stop share, and I'll turn it back to you.
Thank you so much, Dr. Sung. The rigor and scope of the research is very helpful for us. Thank you. Let me open it up for comments and questions from the commissioners. Commissioner McGregor?
That was actually a round of applause, but I definitely do have several questions. Thank you so much, Dr. Song, for a really rich presentation with such a preponderance of evidence across different care settings. Definitely very informative. So I'll start with my first question, which is about really about the occurrence of closure in the wake of private equity acquisition. So you mentioned the case of Hahnemann Hospital in Philadelphia, a very important safety net hospital in Philly. It was affiliated with Drexel as a very important teaching hospital. Also had a majority of its patients were reliant on Medicaid, and a majority of its patients were also Black or Latino. So that loss to the Philadelphia community was certainly felt among some of the most marginalized populations in Philly. Now, you mentioned that Hahnemann was sort of the exception to the rule of the sort of typical private equity model. And I wondered first why you say that they're the exception. And then I also wonder, especially with the promise that private equities makes to sort of turn around providers and hospitals that might be struggling in terms of quality, for example, and financially. That promise, it's so seductive, it's so appealing, but to see the evidence that you presented around the deterioration of quality that we see after a private equity acquisition, it's extremely worrisome, as well as the possibility that one of the exit strategies is bankruptcy, and as we see with Hahnemann, closure. So could you speak a little bit to why you feel that Hahnemann is the exception, and also the extent to which you're seeing private equity acquisitions among the sort of high public payer or the Black and Latino serving hospitals?
Thank you, Dr. McGregor. Great question. And the reason I said that it is more the exception rather than the rule is simply that the rule tends to be a profitable acquisition that is then sold several years down the road for returns to investors in the parent private equity firm. Bankruptcies do happen. There is literature both in and outside of healthcare, particularly outside of healthcare at the moment, that suggests that the bankruptcy rates of private equity owned businesses is roughly 10x that of the bankruptcy rates of non-private equity comparable businesses. This is mostly outside of healthcare. So bankruptcies do happen at a higher rate. However, in the grand scheme, if you look at the total pie of private equity acquisitions, most of them are profitable. Most of them turn out to be profitable for the investors, profitable for the parent private equity firm. Otherwise, we probably wouldn't see all of this activity going on year after year. So the exception is that Hahnemann Hospital had this closure and bankruptcy and a use of its land and buildings in ways that were quite striking to the public. And it happened in a public way, and it was covered in a public way, and it motivated a lot of interest in private equity. But if we were to think of all hospitals acquired by private equity, most of them, the vast majority of them, do not go down the type of journey that Hahnemann hospitals took. It's not to say, however, that journey isn't important, because as you noted, many vulnerable communities are seeing their healthcare providers increasingly acquired by private equity. In our work so far, we have tried to look at disparities at the race or ethnicity margin, or that dimension. And we haven't seen, at least in the hospital setting, a relative difference in outcomes by Medicare beneficiaries of different race and ethnicity. But a lot of this activity is in perhaps Medicaid or outside of Medicare, at least. So we don't really yet know much about disparities or the equity part of private equity. But as far as hospitals are concerned, the Hospital Corporation of America acquisition in 2006 sort of kicked off a lot of subsequent acquisition activity among private equity firms. That was a big acquisition of hospitals that tended to then be sold to another owner and tended to remain open. And that was seen as an example by private equity firms 15, 20 years ago of the hospital sector and healthcare being potentially profitable. And it sort of opened the floodgates.
Thank you so
Commissioner
much.
Cutler? Thank you.
So thank you, Zuri. This was like just a masterful presentation. So I want to thank you for that.
Thank you, Dave.
I had sort of two related questions. The first one is, you sort of you were careful to distinguish between private equity and venture capital backed investment, and you said one was a venture capital backed investment was probably better than the private equity backed investment based on the incentives and so on.
I wouldn't say better necessarily. I was trying to describe it or characterize it as different in the amount and the duration of the holding and the multiples of returns that it's going after.
Fair enough. Is there gradation within private equity type ownership that is some things we should be more concerned about as opposed to less? And then the somewhat related question is, at the end, you gave a bit of a list of where regulatory policy is. And I'm wondering, is there anything that was not on the list that we should be thinking of, or anything on the list that you say, well, this, so think of us not as like passive studiers of what the state does, but, you know, we know people in this state of Massachusetts who we can talk to. And sort of, if there's something we should be doing, it would be good to alert us to that or to raise the issues with us.
Got it. Thank you, David. Let me share my screen for another moment here, if that's okay. I'm just going to go back to the framework model for, can you guys see this slide for private equity? Okay. Thank you, David, for that question. It is indeed the case that there's a lot of variation in the deal. Let me just flip this. In the deals used for acquisition. If this is still showing up on your slide, we'll stay here for a moment. So one of the elements of variation is this dotted white line here. There are some physician practice acquisitions where reportedly the percent debt used is rather small. And this mostly is an equity buy. What that allows is for the providers who are being acquired to not feel the pressure to start paying down interest on the debt. I think that is important because it is more emblematic of a traditional private sector acquisition, either by an AMC or a hospital, or even a for-profit hospital chain. In physician practices, there is also variation on who else is involved here. So for example, some of these acquisitions are not of physician management companies per se, but of other companies who are then working with these providers to help them deal with or engage with either a value-based payment contract or a Medicare Advantage product or a risk adjustment issue, or essentially how to keep people healthy under a capitation so you get to keep more. There are a lot of these physician-run companies that provide expertise at a clinical level that private equity companies may not have at its parent firm level that are part of this structure. And so they may not be the providers, but they may be private equity backed. There's also variation in this management fee here at the top, to what extent this is used. There are at least some reported instances where there are no management fees here, but the management fees all come from your investors and all come after the hurdle after the sale. And then there's variation on who loans the money. May have a big investment bank here contributing to the debt. There's also there are other entities who could loan, but banks I think is a good canonical example. In terms of this other arrow, which we didn't talk about, there certainly is variation here too. So collateral, it's what's being put forth to basically substantiate the loan. We often think of this as the land, the buildings, the machines, the tools, the ORs, the beds, the physical infrastructure. Well, it turns out that, as you noted in your question, venture capital type backed acquisitions tend to go after earlier stage ideas that don't live in a building, that don't have a machine next to it, that don't have a piece of land. And so what's going on with collateral there? The collateral is basically the idea as opposed to physical infrastructure. You can argue that it entails more risk or maybe a different type of risk, but what's collateralized is kind of time and future revenue. That's collateralized. Here in historical traditional hospital and nursing home and some physician practice scenarios, what's collateralized is the physical infrastructure. And I'll finally note that limited partners also vary across private equity firms. And this is a very opaque area, but I've just given you the list of kind of top investors in our country. The CalPERS, California Retirees of Pensions, CalPERS being a big example, teachers, unions, pensions, another example elsewhere, university endowments, sovereign funds, and the wealthy individuals. Hospitals themselves have been known to also contribute to private equity. So there's a bit of a circularity there that's worth exploring. The last part of your question, which I'll just go to the last part of our slides for, deals with this list. So on this list, what's probably missing the most is maybe an R here for regulation. By that, I mean something to do with staffing ratios. So we've seen in the nursing home context that nursing assistants per day drops correlated with increases in mortality. We've seen in hospitals that staffing FTEs drops correlated with the quality of care that we're finding here in this forthcoming work. And in the physician practices space, we haven't found much changes in quality so far. We also haven't looked very deeply, but what we have seen are changes in staffing. So if staffing is really canonical of the classic model, which outside of healthcare we sort of know is the case, then potentially some R for regulation for staffing like nursing ratios or PA ratios or MP clinician ratios or nurse to bed ratios, which we've long talked about outside of this context for hospitals. Something like that for nursing homes or hospitals might be a form of regulation that, based on the evidence, could protect patients on the margin.
Thank you, Dr. Sung.
Thank you.
And now for a last question, only due to time. As you can see, we could probably continue this discussion all afternoon, but for the last question, I'll turn to Commissioner Foley.
Thank you. Part of my question was actually addressed in the last answer, which was, I think one of the things that was missing from the levers slide here was the impact on the workforce. And I think you spoke to some additional tools or levers that we should think about to address some of the potential impacts of these transactions on the workforce. And I think thinking about that a lot during this conversation. And as folks may remember, I asked the question during our cost trends hearings to the for-profit hospital providers there about our recommendation that there would be more of a stringent requirement oversight by the Health Policy Commission and others about the rising for-profit entities in our healthcare delivery system. And they said, no, that doesn't matter. Tax status shouldn't have an impact. And clearly, I think what we're seeing here that in fact does significantly and reinforces the need for us to move forward with the recommendation and come up with ideas to move forward. And so you answered my question. The one thing I wanted to ask, I guess, beyond the workforce impacts is one area of the healthcare delivery system that I didn't see reference and wondering if there's been any research on is home care. That clearly the nursing home space is one, hospice is another, and you talked about hospitals and physicians, but I've also seen in my role growing privatization of home care services as well. I'm just wondering what the research suggests there, if there's been some or if any is forthcoming about the impact of private equity investments in home care.
Thank you, Commissioner Foley. I resonate with your question substantially, and I think from the academic literature, we have not had much insight into home care so far. From a claims perspective, let's say in traditional Medicare claims, much of home care is not visible. And this was analogous to what we faced in studying physician practices, where just identifying the acquisitions themselves was challenging. I mean, here I really want to emphasize credit again to Joe Brutch, to Yashaswini Singh, to Jane Zhu, to Sneha Kannan, to our colleagues elsewhere. All of these junior colleagues of ours spent many years, either of their graduate school dissertation or early faculty life, identifying private equity acquisitions by piecing them together with public sources, SEC reports or public reports or hospital postings or the trade press or PitchBook and other sources. We do use PitchBook for a lot of this work. And at the end of the day, we do see some changes in the, say, practice title or the practice location that make it difficult to track or attribute a particular provider to a practice. What that told us was that there really is, as David Selt said earlier on, a lack of transparency, not just in the impact, but also of the acquisitions themselves. Even when you have data, it took a year to build the sample for the hospital work. It took another year to build the sample for the physician practice work. And on nursing homes, which our colleagues elsewhere at Penn and elsewhere have done, I don't know how long that took them, but probably a long time as well. And in home care, we just haven't dug into that much. Maybe if we have one other minute, Chair DeVoe, I wanted to cover just a small bit of nuance here that I think is on the horizon of what we could do with our private equity samples. And that goes to this, one of the last slides here in your deck. This is showing physician level variations in appropriateness. And I'm only putting this here because of this emphasis in a lot of private equity acquisitions of helping providers adapt to value-based payment. You see that a lot, and it's not clear what that really means yet. Not sure if that is a sort of a slogan used given the era that we're in, or something more tangible about what private equity firms are doing. But if you think about how we define value, classically it was the quality or outcomes of the services delivered divided by some measure of price to society. What we didn't have was a coefficient or this multiplier of appropriateness. And so in the old style of thinking about this in the data, you could have a patient who received a procedure, had a really great quality, let's say no bleeding, no pain, no complications, divided by a very low price to society, and that could appear to be high value. But if it was a patient who did not need the procedure in the first place, we would not necessarily call that high value. And so appropriateness is something we're beginning to be able to study in the data. And with a number of colleagues here of different subspecialties, this initial paper is looking at a within market variation in physician level appropriateness for what we can observe to be similar patients or patients in the same clinical situation. And so this is something we'll try to explore in private equity to see what is their appropriateness of services delivered in a given clinical situation. Is this just sort of one layer deeper into the results we walk through today? This one example on the left is spinal fusions for low back pain. Low back pain is extremely common. Spinal fusions are often done, but within the same market here, with every dot being either a neurosurgeon or orthopedic surgeon, ostensibly speaking, at least in the data, the same quote unquote patient walking into the same specialists in the same clinical situation, same patient, same specialty for the physician in the same market. So the geographic area where people could choose or vote with their feet, where employers could nudge their covered lives on where to go. We just see dramatic variation in the proportion of something that is on average less appropriate versus more appropriate. So spinal fusion for new low back pain without red flag signs, without infection or pain is on average inappropriate. And yet we see many physicians here on the right side of the graph doing them 60, 70, 80, 90% of the time for all of these patients who walk in with new low back pain. But in the same market, we also have physicians who do this a small share of the time for the same patients in the same clinical situation. So does private equity participate in a variation like this will be important for us to uncover. And I also don't want to overblow this or over dramatize this, because although it is true in scenarios like spinal fusion for low back pain, it is less striking for a scenario like an upper endoscopy with no alarm symptoms. Similar kind of consideration, but here physicians are much less variable in the likelihood of scoping a patient. So we'll have to choose the right clinical situation. We'll have to define appropriateness in a clean way, and hopefully we'll be able to learn both in the outpatient and in the inpatient setting whether appropriateness is different after acquisition. Thank you so much for your time. It's really an honor to be here with you. I'll stop here.
Thank you so much, Dr. Song, and we'll look forward to following your work as it continues. Thank you. And now I'd like to turn it over to David Seltz to introduce now our look at the same issues in Massachusetts.
Great. Thank you. And thank you, Zuri. And before we turn to the HPC research, I did want to give you an opportunity to say a few words on your last slide, which goes to this question of, obviously from a corporate structure, there's a lot of incentive to increase charges, increase prices, increase volume, increase cash flow. But how does that translate down to the physician level? How are physicians and clinicians practicing medicine kind of feeling those motivations in the way that they're delivering care?
Thank you, David. I wasn't expecting you to put the slides back up. I guess you have the slides as well. Thank you for that question. I've thought about this often, and this was the final slide, trying to capture some of this. I would say that the era of burnout among clinicians that we're living in, it is real in many settings that you can see on the ground, but it's also reflected in different ways. Some of this tied to financial incentives. And a phrase like moral injury is something that you may have come across recently. We still don't have a full understanding of what that is or a full characterization of it. But this is one personal example that I do think David is familiar with from a prior setting that I often think about. This was a colleague of mine who works at a hospital, not to be named, but one that does use Epic, where, of course, coding incentives are important for reimbursement. And this is a message that this colleague of mine received soon after his patient died on the inpatient unit. And in his words, quote, "The body was not even cold when before he received this message, expressing condolences here at the top and immediately asking him to basically code the 3 codable codes, which are payable HCCs under the risk adjustment." So these clinical documentation integrity or CDI queries are often what we see in hospital settings now, not just after acquisition, but I think just secularly increasing as well. For example, when I first started on the inpatient unit after residency in 2017, I might receive 2 or 3 of this kind of request to essentially code a payable code onto a patient, maybe per week, 2 to 3 per week. And now, if I do a rotation on the inpatient unit with our resident teams, it's more like 4 to 6 a day. So much more frequent we're facing requests like this. And they're also much more multiple. So this 3 here was striking, because often in years past, we just receive 1 per patient. This might be something like type 2 diabetes with XYZ or protein calorie malnutrition. We've talked about this in the Medicare Advantage context. I won't take more of your time here. But this makes me think deeply about how financial incentives translated to the front lines of practice affect the moral motivations of our physicians. For this particular colleague, he was quite demoralized. When he shared this with me, he was sort of exasperated and made comments like, I've been a loyal foot soldier here and done everything that the corporate entity has asked for many years, but my patient had just died, the body was not yet cold, and here comes this request. And so that sunk in with me. Thank you, David.
Thank you. And thank you for sharing that personal reflection. We want to shift now to the HPC team, and I'm going to turn it over to Yua, who is a manager on our research and cost trends team, who's going to present some novel research building off of Dr. Song's presentation about what we have found in terms of trends in private equity investment in healthcare specific to Massachusetts. So I'm going to turn it right over to you.
Great. Good afternoon, commissioners. I am really pleased to share this work with you that we have worked on for many months. Before I start, I do want to acknowledge Dhruv Mandalia on the research and cost trends team and our colleagues from the market oversight and transformation team, especially Sasha Hughes-Rustov and Kathy Mick for their expertise and contribution to this project. So I'll breeze through the background here since Dr. Song has already given a really comprehensive introduction to private equity. But as he indicated, private equity has been expanding into healthcare and the acquisitions have really accelerated in recent years. One analysis found that PE firms acquired 75 physician practices in 2012 nationwide, and that number has gone up to 484 in 2021. Dr. Song also noted a lot of market transactions now increasingly involve third-party management organizations. This is a way for-profit entities, including private equity, to enter into healthcare without violating the corporate practice of medicine prohibitions, but this could increase complexity in the system and potentially lead to increased prices. And of course, all of this is happening against the backdrop of ongoing consolidation in the healthcare market overall. On the next slide, this is just an alternative version of kind of Dr. Song showed how a private equity fund, so I won't go through it, but I think it is a good illustration that just shows how complicated these corporate structures are, and which makes it really difficult for researchers to track when a company is in a private equity's portfolio. On the next slide here, Dr. Song has covered these topics extensively. I kind of just want to highlight again that private equity is unique and different from other for-profit healthcare entities in that they are pursuing high returns in a short time frame using a variety of different strategies, but in particular, the aggressive use of debt is unique to private equity. And of course, in the pursuit of profits, their investments could have implications on spending, quality of care, as well as the workforce. So on the next slide, I'll start talking about our analysis. And our goal here is really to understand the extent of private equity investments in Massachusetts healthcare. And to do this, we analyze the number of provider mergers and acquisitions in Massachusetts. Of course, the number of deals is not a perfect measure. Some deals are going to be big, some deals are going to be small, but given these are private deals, we often don't know the value of the deal. So the number of deals that happen is sort of the best measure we have. We counted the number of mergers and acquisitions with and without private equity in our state. And we defined private equity firms pretty broadly here. We included both firms that specialize in private equity, but also firms that have multiple investment strategies that have a PE division. And again, given the complex corporate structure, we had to use three different data sets to gather as many transactions as possible. We used HPC's own material change notice filings, as well as FactSet and LevenPro, which are proprietary data sets that track healthcare transactions. We included transactions from 2013 to the end of 2022, and we defined private equity acquisitions in three different ways. One is when a private equity firm acquires a company directly. And the second way is the private equity acquires a company and then uses the company as a platform to then acquire subsidiaries. We also count that as a private equity acquisition. And then lastly, sometimes in a minority of cases, a private equity firm might make a non-controlling investment into a firm, so they don't own the company, but they have stake in the company. We also count that as private equity acquisition. Lastly, an important methodological note, transactions were, we categorize these transactions based on the business of the acquired provider, and all of the providers need to be based in Massachusetts to be included in our analysis. And this is regardless of where the acquirer is located. So the PE firm or another corporate acquirer may be located in another state in the United States, or even be located in another country. We don't care where the acquirer is. We just care that the acquired provider is in Massachusetts. Okay, on to the next slide. We did have some exclusions. We excluded canceled or transactions that were still pending by the end of 2022. We excluded transactions of entities that were not patient-facing. So these might be labs or device manufacturers or biotech firms. We also excluded transactions of entities that might be patient-facing, but largely operate outside of the insurance system. So an example of this is an e-health company. We also excluded partnerships that are kind of contracting or affiliation in nature. And lastly, we excluded a small number of transactions between providers and payers. If an acquisition included multiple entities that were announced together, or if they all happen on the same day, we count that as one transaction, regardless of how many providers were involved in that one deal. Okay, so on to the results. So from 2013 to 2022, our analysis found 158 provider transactions in Massachusetts. And again, this is including those with and without private equity investments. And within the 158 transactions, we found that home health and the behavioral health sectors saw the largest number of mergers and acquisitions in this decade. And then you can move on to the next slide. The next slide here shows the same number of 158 transactions, except in the shaded portion of the bar shows the transactions that have some sort of private equity involvement. And the vast majority of these are private equity acquisitions, but there's a small number of exits. So altogether, among the 158 transactions, we found that 71 transactions, or 45%, involved private equity firms. Of these, 62 were private equity acquisitions, 2 were private equity exits, meaning they sold, the private equity owner sold the provider to someone else. And 7 of them were acquisitions and exits. This is kind of the case that Dr. Sloan talked about, a secondary private equity acquisition where a PE firm sold to another PE firm. And by sector, we saw that private equity investments, back to the last slide for a second, thank you. By sector, we saw that private equity investments have been particularly active among behavioral health providers, home health providers, and certain specialty providers. For example, I think the 5th bar, it's dental. The entire bar is shaded, so all of the transactions we identified involved private equity. And same with physical therapy. There's a pretty high percent of the transactions involved a private equity firm. Okay, on the next slide. Here we show the private equity investments in Massachusetts over time, and you can see here that the PE investments here in Massachusetts have really accelerated in recent years, particularly in since 2020. On the next slide here, we're trying to give you a sense of the patterns in which these private equity firms are making acquisitions by sector. So each bubble here represents a private equity firm that has made acquisitions in a particular sector. And the size of the bubble, it's proportional to the number of acquisitions that firm made. So as an example, if you look at the bottom left of this chart, the blue bubble, and that's in the behavioral health sector, the size of the bubble indicates that a private equity firm made 4 provider transactions in the behavioral health space. Another example, under dental, you see a big green bubble there. That means a different private equity firm made 8 dental transactions there. So the bubble color represents a distinct firm. So I think there are a couple things here to note. You can see there are a lot of small bubbles, which means that many private equity transactions in Massachusetts are one-offs, where the private equity firm just makes one acquisition. Though we see that there are some larger bubbles. That means, there are some instances where the individual PE firms are acquiring multiple practices in the same sector. And we see that they do tend to specialize, right? They pick a sector and they make acquisitions within that sector. And we do see that there are variations by sector. For example, in behavioral health, there are some PE firms that acquire multiple practices. There are some PE firms that just make one acquisition. In contrast, in the physical therapy space, there were just 2 private equity firms, but they acquired multiple practices in that space. I do want to know that given our analysis includes only providers, acquired providers based in Massachusetts, it's possible that in these cases of one-offs, the private equity firm is also making acquisitions in neighboring states so that they can establish a regional presence. But given we have a Massachusetts focus, that we do see that many transactions are just sort of one-offs. Okay, on to the next slide. Here, some of the categories we had were relatively straightforward, but we did have a couple of categories that I wanted to provide some more details on. So for the behavioral health provider, the behavioral health sector, where we saw 20 private equity transactions, 9 of them were acquisitions of pediatric behavioral and developmental disorder providers. And this is consistent with a trend that we have seen nationwide of private equity expanding into pediatric developmental disorder provider space. There was a recent analysis that found between 2017 to 2022, private equity firms made 85% of all mergers and acquisitions in the autism service space. So they are expanding into this sector in a significant way, and we're seeing that here in Massachusetts. And the rest of the acquisitions in the behavioral health space mostly involved substance use treatment and or mental health providers. In the nursing and rehab sector, both of the acquisitions we saw were inpatient rehab facilities, and 2 of the transactions were the 2 private equity exits that I mentioned. And within the single specialty provider space, and Dr. Sol mentioned this as well, we saw transactions in the ophthalmology space. There were 4 transactions there. 2 transactions were orthopedics providers, and we saw 1 transaction that involved GI providers. And I believe the next slide just gives you a kind of a summary of my presentation. So we found that consistent with national trends, private equity investments have accelerated in Massachusetts, particularly since 2020. Dr. Song gave a great presentation on the impact of private equity on healthcare services. They can lead to higher prices and often associated with worse quality of care. And certainly there are opportunities to increase transparency and the impact of their financial strategy, and to minimize the harm of kind of these financial strategies on the healthcare market. So what do? I think is the big question, and I think we hope to have more robust discussion on policy levers in a future meeting. So I'll pause there and take any questions.
Great, thank you. Questions or comments? Go ahead.
If I may, Deb,
Please.
a very basic question. What makes a sector, or a particular illness such as autism appealing for private equity companies? What are the factors that go into that?
That's a great question. We could go back to the slide that shows the bubbles. So I think private equity firms use different strategies, and their motivation to enter a particular sector might be sector specific. But I do think that you can see kind of across the board where private equity has been active. These providers tend to be more fragmented and have not been consolidated as much. We also see a pattern where the areas where private equity has been active are where there might be, for example, opportunities for self-pay, right? We see that in kind of dental, physical therapy, and certain specialty. In certain specialties like dermatology, there might be opportunities for private pay. So private equity firms might see that as an opportunity for revenue. In the case of autism services, I believe this has to do with, up until really 10, 15 years ago, autism services, things like adaptive behavioral therapy, were not largely covered by insurance. And in more recent years, given the state mandate, adaptive behavioral therapy, for example, have all become mandatory services. So the PE firms kind of see this as an opportunity given the large volume. So they have really expanded their presence into this space.
Thank you. Commissioner Foley?
Yeah, thanks. Great presentation. It's always good to see the local impacts of how this is playing out here, and helps to inform how we should be thinking about it, and points out to my earlier question about really understanding the home care space. I think is really important. And I think we should continue. I don't know if it was a slide before that had maybe home care and hospice separate, but just I think thinking about those as different entities is really important. There's not much similarities, but there's a lot of differences there. So I just think that is really important. And then the single specialty medical provider, does that capture like services that are currently being provided by the hospital that are now being provided by a for-profit entity like LabCorp coming in and taking the lab services? Is that where that's captured?
No, so labs in this analysis were excluded. The single specialty providers, we're mostly talking about ophthalmology providers, GI, dermatology, this type of, versus the multi-specialty medical provider are kind of physician groups.
I'm wondering how we can or could in the future capture. I mean, that's what I'm seeing a lot of in hospitals, is that their individual services are being purchased by private equity, not the whole hospital, but particular services. I think we've seen that in some of the reviews that we've done in the HPC as well. So I don't know how that gets captured or seen, but I think it's a growing concern that I have is individual services provided by the not-for-profit hospital are being now provided by a for-profit entity within that system. And I'd like to kind of figure out how that plays out within the market in Massachusetts.
Right. I believe our data, the data sources that we have would capture the deals where they are acquisitions. If a for-profit entity, is acquiring, certain services of a hospital. If things are more contracts or affiliation in nature, some of them might be captured by our MCN process, but of course, we have a reporting threshold that might not capture every single affiliation changes in the state, but we should see a large number of them.
Right, it might be a contracting issue versus a purchasing. That's okay. Thanks.
Yeah, good point. Commissioner Cohen?
Just this is a great presentation. Thank you. I'm curious on the behavioral health, the home health, hospice, and probably the nursing or rehab facility. Are you seeing a difference between for-profit and not-for-profit institutions?
The for-profit or nonprofit status of the provider that's being acquired?
Yes.
Oh, great question. That is not something that we have looked into, but we certainly can. It is, if a deal goes back many years, it might be difficult to find information on a particular provider, but especially on the more recent transactions, we should be able to find information on the acquired.
I'm just sort of curious in the future whether the large number of not-for-profit providers we have in those spaces may be targets for future acquisition.
Great, thank you. It sounds like we could add that. Terrific. Well,
Is there
thank you
room for
so
one more?
much. Sure. Yeah, absolutely. Please.
Pardon me. So first of all, wonderful presentation. Just definitely a great first look at private equity in the state. My question is around the role of private equity firms that are outside of Massachusetts. Were you able to look at those numbers? To what extent are the firms that are acquiring these providers located in Massachusetts or located elsewhere?
That's a great question. It's our data sources would give us with the exception of the MCN, which is focused on transactions that happen in Massachusetts, the other two data sources would allow us to look at transactions that happened outside of the state. So if we're interested in seeing if a particular PE firm is, making acquisitions in Massachusetts as well as other New England states, for example, it's something that we are able to do. And anecdotally, we do know that I think the dental example that I showed, it's this particular PE firm was making acquisitions all over New England. So anecdotally, we know that to be true, and our data sources would give us the capability to do that if we wanted to. It is a manually really intensive process to go through each one of these transactions and understand who is buying what and when is the acquirer owned by PE firms. So it's an intensive process, but it's knowable.
Right. Well, if there's reason to believe that an outside firm might have different sort of incentives at play, it could be worthwhile. But just one thought.
Thank you. Well, thank you, for a great presentation, and thank you, commissioners, for the dialogue on this important topic today. I did want to carve out as much time as we could in this meeting because this is just such an important topic, and I think one that I expect we will return to again and again in the next year as we continue to understand what the impacts of these transactions have in Massachusetts and what policy levers should we be considering in terms of both transparency and oversight, protections for patients. As Yua just mentioned, the work that she just presented, which is really just kind of a baseline understanding of the number of transactions, was really manually intensive. We were stitching together multiple data sets, Googling to check, all of these different transactions. And I think that just, again, demonstrates the lack of consistent reporting and transparency here. We have a very robust process for having notice of material changes come before the HPC that we review and track. Many of the transactions that you identified in that analysis were never noticed to the HPC. They were never a material change notice, and there was no way that we would have ever even known that they happened, but for being able to kind of stitch together some of these proprietary data sets and being able to go back in time and look and see what has happened. That to me is an area that is calling out for some policy reform. And I think a great transition to our next agenda topic, which is
David, I don't want to belabor this, but I do want to say, I wonder if you could ask the team to do some research of whether we need to broaden our legislative mandate, because I'm sure most of what the team pieced together never came in front of us. So do we have the mandate to review this, or do we need a broader remit? I'm not very good at this government stuff, but it does seem like the legislative intent and all that stuff is important as we try to reform. I'm impressed at the policy implications it has, so it might be worth having somebody take a look at that.
Absolutely, Secretary Walsh, and I absolutely appreciate that. I do see that there is a need for some statutory changes to make clear that these types of transactions should be noticed to the HPC. And I think there are other, of course, regulatory agencies like the Attorney General's Office and the Department of Public Health who have important roles here. So I think as we move forward, would love to work with you and your team about what changes might be most appropriate.
And both presentations highlighted adjacent businesses. We're always focused on the hospital bed, but the action is outside that right now. So.
Absolutely. Yeah, I think nationwide, Dr. Song talked a lot about hospital acquisitions in the PE space. That has not been the trend here in Massachusetts by and large. It's really the evidence that you showed: behavioral health, home health, some long-term care. So excellent point. Great. So some more to come on this topic. But now we wanted to transition to the next agenda item, which is our regular update on our notices of material change that we have before us at the HPC, and did want to spend a few minutes briefing the board and the public about some new notable filings that we've received since the last time we met. So I'm going to turn this over to you, Sasha, and ask that you move us through some of the transactions that are already are under review, and spend a little bit more time on some of the newer filings. But go ahead, Sasha.
Absolutely. Thank you, David. Good afternoon, commissioners. I will try to be expeditious, given time. Since we started reviewing notices of material change in 2013, we've reviewed a total now of 162 market changes, with formation of contracting entities being the most common. Notices on which we have elected not to proceed since our last meeting are 4 transactions. The proposed acquisition of Tufts Medicine's outreach lab assets by LabCorp, the Laboratory Corporation Holdings of America. Under the transaction, LabCorp purchased and will be operating the outreach lab business of the Tufts Medicine Hospitals, Tufts Medical Center, Lowell General, and Melrose Wakefield. Outreach lab services are labs for patients who are not hospital patients at the time of service. Samples gathered in physician offices, nursing homes, other collection facilities that are brought to the lab and run there. In our preliminary examination, we found limited scope for spending increases due to the transactions. You may recall from our cross-trends reports, LabCorp has amongst the lowest prices for lab services in the state as compared to other hospitals, including Tufts. And we didn't review evidence that the transaction is likely to negatively impact clinical quality or access to care. Second transaction was between Greater Boston Urology and US Urology Partners, which is a national management services organization backed by private equity, I will note. As with many MSO transactions, US Urology Partners acquired the non-clinical assets of Greater Boston Urology. GBU continues to operate the clinical practice. The MSO runs essentially back-end services. We found that there are factors that are likely to limit any potential impacts of spending in this transaction, primarily because Greater Boston Urology contracts with commercial payers through existing affiliations with Massachusetts ACOs that are going to limit any changes in prices or market leverage as those relationships continue. We didn't review any evidence that the transaction is likely to negatively impact quality in any specific ways, but we intend to keep track of this affiliation as part of all of the broader work that we've just discussed, understanding the role of private equity in the Massachusetts market. Third, the proposed affiliation between Tufts Medicine and LabCorp, under which LabCorp proposes to manage the hospital laboratories at Tufts Medicine's hospitals, not acquiring the business, but rather staffing and providing operations at those labs. In the preliminary examination of that affiliation, we found limited scope for potential changes in spending and market impacts. because the lab staffing and management will be done by LabCorp, but Tufts will continue to bill for services under its own payer contracts. So there's no change vis-a-vis payers or consumers as a result of the affiliation. And we didn't identify any evidence that the transaction is likely to negatively impact quality or access. And fourth and finally, the proposed affiliation between Tufts and Sturdy Health, under which Tufts will be staffing Sturdy's hospital pathology service. Here again, we found the transactions unlikely to have a significant impact on spending, competition, or quality, and indeed ensuring that Sturdy can staff its pathology service, of course, is likely to promote access to care in Sturdy's community. On the next slide, you see the beginning of 7 additional proposed transactions for which we received notice since our last board meeting. Going to run through these very quickly. A proposed acquisition of Amedisys, which is a for-profit home health and hospice care company by United Health Group, their Optum Health subsidiary. The proposed acquisition of outreach laboratory assets at Bay State Medical Center by LabCorp. A proposed reorganization of some of the legacy Beth Israel Lahey Health contracting organizations under the Beth Israel Lahey Health Performance Network, which is BILH's umbrella contracting organization. On the next slide, a proposal for MCIPA, the Mount Auburn Cambridge Independent Practice Association, to become a member of BILH's Physician LLC, which contracts on behalf of independent physicians under BILH. A proposed joint venture between the Greater Springfield Surgery Center and Mercy Medical Center, under which Mercy would buy into a stake in an existing ASC in Springfield. A new proposed joint venture between the Atrius MSO, the Optum subsidiary that owns Atrius Health now, and Shields Imaging Services to stand up a new PET CT service in Dedham. And finally, the proposed clinical affiliation between Dana-Farber Cancer Institute and Beth Israel Deaconess Medical Center and HMFP, under which they would collaborate to provide cancer care services in Longwood, anchored by the joint construction of a new hospital facility for Dana-Farber. And I want to spend the next few slides sort of reviewing some of the particulars of that transaction, as it is a really significant proposed change. You're all familiar with a lot of this story, but to briefly summarize from the public information, Dana-Farber, DFCI, is a cancer research institution and a provider organization. It provides inpatient and outpatient services at both its own hospital, its licensed outpatient sites, and a number of partner sites, clinical affiliates statewide, largely other hospitals. Its hospital is primarily outpatient, but it has 30 licensed inpatient beds that it leases from Brigham and Women's Hospital as part of a longstanding affiliation. And it also provides medical oncology services to Brigham and Women's patients in Brigham and Women's Hospital beds, in addition to the 30 beds of its own that it leases and staffs. Earlier this year, of course, Dana-Farber announced it's going to end its affiliation with Brigham and Mass General Brigham, and has proposed a new collaboration with BIDMIC and HMFP. That affiliation would be anchored by the construction of a new facility for Dana-Farber adjacent to BIDMIC on the current site of the Joslin Diabetes Center. So the HPC is reviewing that affiliation, including the proposed joint construction. The Department of Public Health's Determination of Need program also has concurrent oversight over the application by Dana-Farber to build its new facility. And on the next slide, I just sort of put up a couple of the most salient elements, again, from public information at this point of the project. The affiliation involves the construction of the new cancer hospital, which involves at least $1.67 billion in construction cost by Dana-Farber. Dana-Farber will relocate its 30 inpatient beds from Brigham and has proposed 270 new adult inpatient beds in the facility, and the addition of new MRI, CT, PET CT, and LINAC units for diagnosis and treatment of cancer patients. In addition to, as part of constructing that new facility, Dana-Farber and BI and NHMFP are proposing clinical collaborations to staff both the new facility as well as the staffing cancer services at BIDMC in the adjacent hospital. So medical oncology and infusion services would all move to Dana-Farber physicians. Surgical oncology would be provided by BIDMIC and HMFP physicians. And the parties would jointly create a new physician organization and joint venture to handle radiation oncology services provided across the two facilities. So really an enmeshment of the clinical oncology services across all of the different components of oncology care between the two entities, supporting care both at the new facility and at BIDMIC, as part with the new facility as being a sort of important part of the new relationship. On the next slide, I mentioned the concurrent authority of the DON program, so wanted to remind commissioners about that process and its timeline. DFCI, as we understand, is currently working with the DON program to complete its application. And once that application is deemed complete, DPH will post it to their website. DON will decide, in short order thereafter, whether to require an independent cost analysis on the project, and is likely to hold public hearings on the project as well at some point. The total timeline for a DON review is typically 6 months, and staff issue a report on whether the project meets the DON's factors for approval that are spelled out in their regulations, and recommend any conditions on the project necessary for the application to meet those factors. Then the Public Health Council takes a final vote on the application at the end of the review. I'll note that the DON regs contemplate a situation in which a DON application is also being reviewed under the HPC's CMIR process. In that case, even if DON completes its review before the HPC issues its CMIR reports, the DON doesn't go into effect until our process is done. And additionally, the Public Health Council can reopen review to consider information in our CMIR report related to the DON factors. You may recall that this actually did happen when we were reviewing the merger of BILH. DON had concurrent authority there. They had approved the merger with certain conditions and then reopened the review and imposed additional requirements and reporting on BILH based on our findings. Helpful, I think, on the next slide, for comparison on our timeline, which starts, as you know, once we've received a completed notice of material change, including all the relevant documents and information that we need. The DFCI, BIDMIC, HMFP, MCN notice is not yet complete. Once it is, we conduct our initial review, as we always do, to decide whether or not the transaction is likely to have a significant impact on spending or on market functioning, and whether or not, based on those two factors, to initiate a CMIR. The decision to pass on a transaction or to initiate a CMIR has been delegated to the executive director, but if there is a decision to initiate a CMIR, that decision has to be affirmed by the board at its next meeting. And just, when we move on to a CMIR, we request additional information from the parties. The total review time is 185 days from the completed notice, plus any additional time that we need for that results from an extension of time for production. And in the concluding steps of the process, the HPC produces a preliminary report. The parties have an opportunity to respond, and then we develop a final report that incorporates that response and any additional analyses that are needed. The final report is then made public and can be referred formally to the AGO, DPH, or other relevant entities. And parties have to wait at least 30 days after a final report before they close the transaction. So wanted to provide all of the context for comparison of the two processes that are involved here. Obviously, this is, as I have identified, we're still at the preliminary stages of our review, but wanted to provide the full context as this is a pretty significant proposed transaction. And David, anything else to say on this?
No, Sasha, I think you did a great job providing the overview for the board and wanted to give commissioners that update and happy to take any questions you have about what we know so far and what the process would be moving forward.
Everyone's trying to quickly calculate when their terms expire. Sorry.
Okay, well, seeing no comments at this stage, as Sasha said, just to reiterate, we still are in the kind of preliminary review stage of this transaction, but wanted to note that it is a significant change that we're going to be looking at very closely to determine whether a cost and market impact review would be warranted in this case. And so as we continue our review, I will be in touch with all of you board members as we make that decision. So thank you. Thank you, Sasha, for running through all of that, all of those details, and look forward to more conversations on all of these transactions. As Sasha laid out, we have 7 open transactions, all of which are in some cases unique in what they're trying to accomplish. And so the team is very busy right now. Thank you.
Thanks so much. Thanks, Sasha and David. Now we want to turn to our next agenda item, which is to focus on the 2023 cost trends hearings that we held in November, and having had an opportunity to reflect on those hearings and also to get feedback from many of the attendees and members of the public, we wanted to discuss that. And I'll turn it over to David Seltz.
Thank you, Chair DeVoe. And just to give commissioners a sense of the time check here, we do want to conclude our meeting today by entering into executive session and having a confidential discussion of the performance improvement plan review process. So I will try to move through the last remaining agenda items by no later than 2:35, and then move into our executive session for the remainder of our time together. So first, just wanted to reflect back. This is the first time the board has met since our most recent cost trends hearings. I will share my reflections after the hearing, which was I felt it was one of the most impactful and hearings that I have been a part of in my 11 years at the HPC. I thought the panelists and the witnesses all provided tremendous testimony on the themes of affordability and equity. Those themes of affordability and equity that we really placed front and center in both the theme of the day, but also in the presentations, really ran across the day. And I thought there was incredible discussion with you board members and with our witnesses on the relationship and the link between those two dynamics, as well as a lot of conversation about how we might move forward in measuring affordability and measuring health equity and being able to set targets or indices that could track our performance and improvement over time. So the next couple of slides are just some key quotes that we pulled, and then I'll stop and want to hear any additional reflections that board members may have. So on the first slide here, we did something unique in this cost trends hearing, which was to begin the day hearing from community leaders and advocates from across the Commonwealth about their experiences and the experiences of people in their communities on affordability and equity. And this was something that we had not done in this way at a cost trends hearing before. And I'm so personally grateful to the witnesses who participated on this panel, who came before the board to share their personal testimony. It is, can be an intimidating thing to come before the HPC board in this very public setting and to share their thoughts, but they were all so incredibly thoughtful. Pastor Kiki, a quote here, what I frequently hear from people is that they cannot afford the healthcare they need the most. For many in my community, because healthcare is so expensive, they would rather wait until the last minute to seek care and treatment, which, as we know, often leads to more expensive emergency care down the line. Sheila from Lowell Community Health Center added, getting access to care shouldn't be about luck. We have a moral obligation to address these racial inequities in health, and our state has an opportunity to lead. On the next slide, we were also really pleased to be able to hear from our Attorney General. Oh, excuse me. We, after that, heard from leaders on policy solutions. And one quote that we pulled out here from Juan LaPera, the fact that you are putting equal weight to the equity conversation as you are to the affordability conversation just marks the incredible progress and the continued recognition that these two are inextricably linked. And here you can see a picture of many members of the Health Equity Compact who participated in the hearing that day. We're grateful for their partnership. On the next slide, we also had remarks from our Attorney General and our Governor. The Attorney General saying the number one issue we're hearing from constituents is affordability. Everything is just too expensive, including the cost of care. And Governor Healy said healthcare costs are rising. And I'm here just to say that as an administration, we are looking forward to partnering with the HPC and with the legislature on the steps we need to take to reduce healthcare costs across the state. In the afternoon, we had 3 witness panels, one on health plans and the role of health plans. The second was on the changing provider landscape. And finally, a conversation with health system leaders. Kane Hayes on the health plan panel said, although it is a challenging rate negotiation environment, we have to stick to our conviction around increases that are as close to the benchmark as possible. Dr. Chris Andrioli from Atrius Health said the biggest risk, threat, issue to our company and more broadly to healthcare in the Commonwealth is the lack of primary care. And Michael Curry and the last panel, challenging policymakers. There are people dying unnecessarily right now. For us to accept that is disturbing. Are we willing to do something disruptive and change the system and to do it with a sense of urgency? I do think that theme of urgency and finding common solutions also came through across the day. And I'm grateful for commissioners for your incredibly thoughtful comments and for also pressing some of these witnesses to be on the record in terms of their commitments to working with the HPC and working with other state agencies on areas like administrative complexity, on areas like affordability and equity. So I will pause here and just want to have a chance to open it up if any commissioners had any additional reflections about the hearing and your thoughts. I see Patty already raised your hand.
Should I go?
Yes, please.
Oh, okay. Overall, I thought it was terrific as well. I think one of the people that I was very impressed by was, and I'm sorry, I don't remember her name, who heads the Health Connector and the innovation that they're doing with the affordability to businesses, because that's one of the issues we've been trying to wrap our heads around for a long time. So I think it is a good idea for the HPC to work on ways to help promote that as an option for businesses for affordability in the state. And also, I think next year we need to get a stronger speaker representing the employer provider, the employer purchasers of healthcare, because we had one speaker, but it was unclear really that he was talking so much as a purchaser of healthcare because he was in the healthcare business as well. So we did get some testimony after the fact, but I think we do need to have a stronger voice from the employers.
Great, thank you.
Commissioner
Professor
Cutler?
Cutler? Sorry, Deb.
So I thought it was terrific meeting in many different respects. One of the things that struck me, and you mentioned it, David, is when we asked folks directly, because we have our recommendations about administrative costs, and when we asked folks directly, like, is there anything there that you oppose? We basically got from Blue Cross Blue Shield and point 32, we said, no, there's nothing there we oppose. In fact, we'd actually probably go further in terms of some of the underpinnings and information storage and so on. And the person from United sort of didn't particularly answer, but afterwards, just in the hallway, came up and said, well, you know, there's nothing there that we oppose. We just are uncertain about how to deal with 50 different states. But like, there was nothing on the agenda there that we really opposed. And so I took from that that's one area where we could probably move, hopefully fairly rapidly, both with what we can do without the legislature and then what recommendations we would make to the legislature, so that we not lose some of the momentum we've developed around trying to reduce administrative costs. And so I'd really like to kind of keep that high on our agenda as we move into what to do in this coming year. Maybe we could kind of strategize about how we can move forward in the next year.
Thank you, David. I had the absolutely exact reaction to their both Kane and Sarah's commitment to saying, yes, we want to work on this agenda. Let's take them off on that offer. And I think we can really make some progress in the next year on that one. So I noticed that as well. And thank you for the putting them on the spot. Barbara?
Thank you, David. I noticed, I think, two things. And one is the increased willingness to look at the Health Policy Commission as a way of help finding solutions. I think maybe in the past, we hadn't had enough history. Folks didn't feel as though they could trust us in terms of taking on issues. And I think we've overcome that hurdle with providers and with insurance companies. Not to say that they don't see the regulatory responsibility that we have, but I got a sense this time especially of a desire to partner, maybe because the system is so tightly stretched that we have to look to each other to find solutions more than we've had to in the past. I agree that I think the early morning panel was perfectly placed on the agenda. And I think the messages that the panelists brought to us were profound in helping to establish the context of what we were doing going forward. And lastly, I think the idea of looking to those partnerships and looking to create those partnerships and taking advantage of the willingness to look at those partnerships is a critical next step for us. I think they've indicated an interest. I think they're expecting us to perhaps take a step towards, okay, this is how we think we can partner, without at all giving up our regulatory and oversight responsibility. So I thought it was one of the best, if not the best, meeting that we've had since I've been on the commission. Thanks.
Thank you.
Yeah, I want to really underscore what Commissioner Blakely is saying. I felt the same. I felt there was a productive discussion and also an indication that the HPC can play an important role in convening and moving forward on solutions, as well as holding accountable. So I do think this gives us an important jumping off point, as both Commissioner Blakely and Cutler said, for this coming year.
Yes, and if I can interject here, I agree with a lot of the sentiments shared, but one thing that was a bit worrisome to me that seemed to be kind of a recurring theme throughout the testimony was that there were a lot of individuals who expressed a frustration with things not changing, with us. We're talking about the same themes year after year, that they've been coming to this hearing for the last, however many years, and we're still talking about the same issues. So, I just want to emphasize really this quote from Michael Curry that you have up here, the willingness to be disruptive in the types of changes that we propose. as much as possible, because we're facing some huge health issues, and clearly, as we all know, we're leading the country in spending and hospitalizations and such. So definitely just want to underscore that point.
Thank you, Dr. McGregor, and thank you, commissioners, for all of your comments. I do think the cost trends hearing in some ways becomes kind of a launching pad for our agenda for the next calendar year. And so when we meet again in January, I'd love to carve out some time in our agenda to talk again about what are our priorities for calendar year 2024. Where are those areas that we want to really put our emphasis and resources behind to be able to kind of drive our agenda for 2024. So I look forward to a conversation at the next board meeting where we can really kind of talk together about our priorities and where we want to dedicate our time and energy in the next calendar year, and hold ourselves accountable to making progress on those priorities. So in the final minutes of today's meeting, I'm going to skip over some of the slides we had, and I'll talk a little bit about that. But it is the last meeting of the year, and this has been truly a tremendous year at the HPC. And as often we do at the last meeting of the year, we want to take a moment to look back and kind of quantify. We love data here at the HPC to really kind of quantify all of the different work that we did this year. And so to give us a little bit of 2023 by the numbers, I'm going to turn it over to Hannah Klumak. Hi, Hannah. How are you doing?
Excellent. Thank you so much. All right. Well, as David said, I think everybody knows we love it by the numbers. And until Colleen Elstermeyer is back at our next board meeting, I am the HPC's cheerleader in residence. So I'm going to lead us through a few of our exciting key accomplishments and some of the by the numbers things that the HPC has accomplished this year. So building on David's recap of some of the high points of the cost trends hearing, here's a quick by the numbers of the cost trends hearing. And I'll just run through quickly. We had 23 guest speakers and panelists. We presented 70 slides and 1 video, and we were joined by 120 in-person attendees, and we've had over 1,700 views on the live stream. So to everybody who feels like they keep testifying at the hearing, your message is going very far. There's a lot of people who are tuning in and watching that hearing. As you know, the HPC plays many roles, so I have a few highlights from each of our 4 levers. So from our work as a market monitor, importantly, back in March, we set the healthcare cost growth benchmark for 2024 at 3.6%. In 2023, we reviewed 14 material change notices, and we released the 2022 data from our Registry of Provider Organizations, or our RPO program. The 2022 data was from 46 provider organizations and was inclusive of 24,000 physicians. That data is public and it's available on our website if anybody wants to check it out. I couldn't finish the slide without doing a shout out for our Office of Patient Protection. Our OPP team is small but mighty, and they had quite a busy year, almost 1,500 calls to the OPP hotline this year, and a high number of requests for external review and open enrollment waivers. And our OPP annual report is generally released in the early part of the calendar year as a look back, so something, a little sneak peek for next year's report. In our partnership role, we saw some excellent achievements through our investment and certification programs, which includes 42 babies born in the Beside program. That's our program with Bay State and Boston Medical Center, working with doula expertise. There have been over 100 total caregivers and substance-exposed newborns enrolled in our C4SEND program, and over 14 applications for HPC certification for accountable care organizations. We also saw an increase in the statewide fidelity to the aligned measure set. So that adherence is at 92% for 2023, which is up from 85% in 2022. And then lastly, we had 11 outputs published with learnings and outcomes from our investment programs, and those are all available on our website as well. For research and reporting, a lot of research released this year. I know everybody enjoyed their hard copies of the cost trends report that were given out at the cost trends hearing. Over 100 data exhibits are included in that report and chart pack. We released 2 legislatively mandated reports and 3 special policy reports and data chart packs. And we saw over 100 articles citing HPC research and activities in the news this year. In our work as a convener, we had 19 public meetings and events, and that totaled over 50 hours of time that we have all spent together. So thank you so much for your commitment and your time to the HPC. We have also partnered with 21 different states on a variety of projects, including cost growth benchmark setting programs and drug pricing review programs. And the last one that I'll shout out is we had over 1,100 participants in our special event on supporting the healthcare workforce back in March, which was a great event. And we look forward to doing more work on that topic in the future. The last 2 slides that I'm going to share are a little behind the numbers, a little shout out to our team here at the HPC. So a little look at some of the highlights that you don't necessarily see in some of those behind the numbers. So earlier this year, over the summer, we had over 20 of our staff and summer fellows who volunteered at community servings. We've volunteered with community servings for the past few years and love working with them. There's a couple of snapshots of our team at the cost trends hearing, and also a couple photos from when our staff attended the last home game of the season for the Red Sox at Fenway. I won't say anything about what the score of that game was, but we had a great time. We love to cheer. Lastly, just a few of the events that took place this year. So we had sent a number of our staff to the Academy Health annual research meeting this past summer in Seattle. You may have seen on one of the previous by the number slides that one of our abstracts won Best Abstract at the whole conference. So a big shout out to our research team for their work on that. We also sent a number of our staff to the NASHP conference, which was in Boston this year. Very fun to have them local. A snap of Chair DeVoe at the MAP annual conference last month. And a little sneak peek at what we like to call the David Seltz Roadshow. Just a couple of recent presentations that David's given. He was a panelist at the Health Equity Compact's inaugural Health Equity Trend Summit back in June. And then this is a photo from just last month presenting on our policy recommendations at the Greater Boston Chamber of Commerce. So it's been a great year at the HPC, and we're already anxiously awaiting 2024.
Thank you so much, Hannah. I don't know how we'll be able to surpass those numbers in 2024, but I think with coming back, we will find a way. The last piece that we skipped over here in the year in review, which I will save for the January meeting, was a little bit of going back to the beginning of the year when we had identified some of the key priority areas that we wanted to focus on this year. And I did a little bit of a progress report about the key accomplishments that we achieved in each of those areas. I'm going to save that for January because I think it's a good way to kind of look back at the accomplishments we've made and then also to make a plan for 2024. So we'll save some time in the January meeting for that kind of strategic plan for 2024. The last agenda item that I have for you today in the Executive Director's report, well, moving on to the next slide, quickly just wanted to share a slide on recently released and upcoming publications. We'll note some upcoming publications, evaluation of our Shift Care Challenge program. We have an upcoming publication on ambulatory surgery centers and our 2023 fellowship report. Next slide. A huge shout out here to our annual fellowship program, which has been an incredibly successful program at the HPC over a number of years. In 2023, we hosted 11 fellows from 5 universities across the country. This is a 10-week paid fellowship opportunity for graduate students with an interest in health policy who have the opportunity to work alongside HPC staff. This has always been an incredibly competitive process. We have gotten hundreds of applications for this fellowship program in the past, and these fellows have gone on to work in incredible places across the country in health policy, research, academia, and even at the HPC itself. This is just a public notice that we will be issuing our summative report of the 2023 program, as well as opening applications for the 2024 fellowship program soon. We will share that information with all of you commissioners and ask that you share those with your networks so that interested students can find a way to work with us next summer. Next slide. Great. And so the final agenda item, next slide, is a vote here, a proposal for renewing our lease at 50 Milk Street. It's hard to believe, but we have now been in this space at 50 Milk Street for 9 years. We moved into this space 9 years ago and had the ability to custom build this space to our specifications for the HPC, including all of the offices, the cubicles, and the conference centers. This location and this space has been an incredible asset to the agency and to our work. And some of the reasons are shown here on this slide. It is really truly an optimal location in downtown Boston with tremendous access to public transportation, parking, biking, and walking. We have invested in the Altman Conference Center, which has live streaming capabilities. And we make that conference center available to other state agencies and to other organizations. So this is really an asset to the Commonwealth, not just to the Health Policy Commission, to be able to have this space. And included on this slide is some of the recent reservations in 2023. Certainly during the pandemic, we had less demand for that space, but as people have become more and more in person, we're seeing other state agencies really wanting to be able to take advantage of that space, and we are happy to do so. The space accommodates our full staff with some flexibility to move up or down, and we've invested in technology and hybrid capabilities throughout the office. So as we approach the end of this lease term, we engaged with both the broker and the landlord at our current location, as well as the state's Division for Capital Asset Management and Maintenance. That's called DCAM. That's the state agency that really helps us, other state agencies, secure leases and find office space. And so we consulted with both the landlord and with DCAM and are here today to share a proposal to renew our lease for a term of an additional 10.5 years. We negotiated, I think, very competitive rates and provisions. All of the details of the new proposed lease we shared with the committee of the Administration and Finance Committee of the HPC yesterday. We held a public meeting to go in depth through those details and through the negotiation process. Importantly, it includes a provision for 6 months of free rent, no increase in rent in the first year with modest annual increases thereafter, and a generous allowance for us to continue to be able to make office improvements or to actually apply that to rent. Importantly, we did work with DCAM to look at market comps, and the rates that we ultimately negotiated were at the low end or below market comps in this area. And so with that, we are proposing to move forward with a renewal of the lease as negotiated. And I'm here today to seek your vote and approval to do so. I may ask a member of the Administration and Finance Committee who met yesterday to go through the details just to share a little bit about the discussion that we had.
Sure, I'm happy to summarize the discussion that we had yesterday and really appreciate the other commissioners who participated in that. There were a number of questions that we talked about, including the use of the space, other alternatives to continuing our current lease, the specific provisions that are in our lease that are very beneficial to us, including the ability to assign the space if over this 10-year term our needs change. We can assign it to another government agency, which I think is very helpful. And the committee as a whole was pleased that we are not forced to relocate, that the team could negotiate such positive terms on a space that, as David said, is really ideal for us. So other comments by other commissioners who were part of the discussion yesterday?
Deb, I would just add a significant decrease in rent.
Yeah.
Well, thank you. Thank you, members of the committee. I think we can move to the next slide. And Chair DeVoe, if you want to lead this discussion, lead this motion. Thank you.
Yes, great. Can we have a motion to move to a vote for proposing that we execute the lease renewal as proposed?
So moved.
Seconded.
Second.
Thank you. And Hannah, can I turn it over to you to take the vote roll call?
Absolutely. Thank you. I'll start with you, Chair DeVoe.
Approved.
Vice Chair Cohen.
Approved.
Commissioner Blakeney.
Approved.
Commissioner Cutler.
Approved.
Commissioner Foley.
Aye.
Commissioner Haupt.
Approved.
Commissioner Master Giovanni.
Approved.
Commissioner McGregor.
Approved.
Thank you. Commissioner Kwasnick.
Approved.
Secretary Walsh.
Approved.
Thank you so much.
Great result. And thanks so much to the team that negotiated this. David Seltz, any last comments before we move to close the public meeting?
We have one final slide, which is just our public meeting calendar for 2024, which is now available online for the public. Commissioners, you may have already received many of these Outlook invitations to these meetings. We are hoping to have some of these board meetings fully in person. We have, I think, identified the January and July meetings that we would love to have commissioners be able to meet in person for those meetings. We won't do every meeting in person given the travel constraints and other considerations, but did want to kind of have a mix of meetings this year, both in person and continue to be able to utilize remote. So commissioners, we'll share all this information with you and get it on your calendars. But for the public, please put these dates in your calendars. And for the public, I would note one important change is that we are shifting our public meeting days from Wednesdays to Thursdays in 2024. So we will be seeing you on a different day of the week. But with that concludes our agenda for today. We do have one final roll call vote, which is to be able to move us into executive session. For the public, we will not be reconvening in a public session. So this will be the end of the public meeting today. Thank you, everyone, and I wish you a great holiday season, and we'll see you next year. But Hannah, let's move through this motion and vote.
Wonderful. Can I get a motion for the vote?
So moved.
So moved.
Thank you. And a second?
Seconded.
Thank you. Chair DeVoe.
Approved.
Thank you. Vice Chair Cohen.
Approved.
Thank you. Commissioner Blakeney.
Approved.
Thank you. Commissioner Cutler.
Approved.
Thank you. Commissioner Foley.
Aye.
Thank you. Commissioner Haupt.
Approved.
Thank you. Commissioner Master Giovanni.
Approved.
Thank you. Commissioner McGregor.
Approved.
Thank you. Commissioner Kwasnick.
Approved.
Thank you. And Secretary Walsh.
Sorry, approved.
Thank you. And I'll just remind all of the commissioners that we'll hold all conversation for just a moment until we can be certain that the live stream has ended, and then we'll be able to begin our confidential executive session. So thank you so much.